and nationally. Also, the role of Vision 2030, the health and wellness in dealing or in managing patients with chronic conditions, and set forth the policies and guidelines and so forth. Also, the multifaceted impact of chronic respiratory disease on health individuals or in society in general. And we will be introduced today in one of the rehabilitation theory, which emphasizes the trajectory of the disability, which is the Nagy model of disability. Then we will get into a kind of a prime example of how we can apply the Nagy's model and the rehabilitation theory in general, and how to use them in order for us to understand the process of disability or the process of the health impact and so forth. And the last but not least, we will end up my presentation with the one of the rehabilitation theory. And make no mistakes, there are difference between the two theories, in which the last one, which is the Institute of Medicine model for chronic respiratory management, is kind of an enablement process. And the opposite is true with the other theory, which is the Nagy model, which is kind of a depicting of the trajectory of the disability. Now let's get into the first outline of my talk today, which will be the prevalence of chronic respiratory diseases in the world or in the global in general. We have the chronic respiratory conditions represent a significant public health challenge, with asthma and COPD in particular leading as a major contributors to the morbidity and mortality. Now, with the recent data set forth by the World Health Organization, they illustrate the concerning rise in chronic respiratory conditions globally, and that is exacerbated by many factors. And understanding those factors will help the policymakers, clinician researchers, and so forth to set forth guidelines and to understand the triggering factors for triggering the exacerbating the chronic respiratory conditions. And from out of these factors like pollution, smoking, and occupational hazards, and also environmental, and we could include a lot of things in that model to show the triggers of the chronic respiratory conditions. Now, with the World Health Organization's reports and escalating in respiratory diseases, highlighting the urgent need for global health strategies to address these trends. Now, we're done from talking about the world events in terms of the chronic respiratory conditions. Now we have the same thing, as a matter of fact, in Saudi Arabia, in which the prevalence of chronic respiratory conditions in Saudi Arabia has seen a notable increase, and that attributed to factors such as the air quality, environmental factors, smoking rates, and urban lifestyle changes. And the same factors that triggers, as a matter of fact, the chronic conditions in terms of the respiratory conditions in globally, we almost have it here. So we almost share the same triggers, except with some sort of changes with regards to the moderation of the genetics and so forth. Now, the escalating trend in the chronic cardiorespiratory conditions underscores the critical need for targeted healthcare strategies and interventions to manage and prevent these chronic respiratory diseases. Now, to tackle this problem, to tackle this catastrophic events that affect individuals and affect the society in general, the Vision 2030 responds to the rising in the prevalence of chronic respiratory diseases, including the respiratory ones. Saudi Vision lays out a comprehensive plan to transform the healthcare landscape in the kingdom. And the vision basically approach is to the health and wellness encompass and contain and include several factors. So to tackle that in a collective method, to treat or to tackle that matter in a holistic approach. So they set strategies and initiatives designed to transform the healthcare landscape in Saudi Arabia. Of these strategies, we have the promotion of preventive measures. And we had a nice panel discussion yesterday in which they have already touched base that topic in terms of the preventive medicine, the precision medicine, and also to promote the preventive medicine. So the aim of the vision in promotion of preventive medicine is that the emphasis on preventive measures to reduce the incidence of the chronic diseases. So the best way to treat, let's say, a medical concept or a health concept is looking at the causes of the disease or of the concept or the health impact, rather than just looking at the symptoms of the disease. So tackling the original problem is the best way forward in order to solve or target that matter. The second one of that vision, or the second element of that vision, is the enhancement of the healthcare services among the citizen or among the population living in Saudi Arabia. And the whole purpose of that element is to kind of provide the accessibility to the whole population in general. Another thing, which is the third element, which is kind of an integration of the digital health solutions. And if you guys remember from the talk from yesterday, the panel started talking about the artificial intelligence and also how to utilize the machine learning in order to allocate the resources, getting into the bottom of the problem itself through using the artificial intelligence and, in the electronic digital era that we are living in. So the best use of these electronic things and resources would solve a problem, would lead us to good outcomes, and that will help tackling that problem. The fourth element of the Vision 2030 with the health and wellness is the fostering a culture of health and wellness. And the aim of that element is to encourage the adoption of healthy lifestyle and behaviors, and this include initiatives to promote physical activity, such as the development of sports facilities and public parks and so forth. The last but not least is supporting the research process. Now, most of the health institutions here in Saudi Arabia are having offices or guidelines to support the researchers with grants and also with other logistics support. Now, we've talked about the chronic conditions and the chronic condition in terms of the definition and the prevalence. And we know for sure that there will be consequences of the chronic conditions. Now, of these conditions, the impact of chronic respiratory diseases extends beyond the individual. It imposes a lot of problems. It imposes a lot of problems on the health system and the society in general, and that would definitely will cause a burden economically and psychologically on all levels. So, if we would like to go over some impacted conditions resulted from the respiratory diseases, one we've talked about the physically. Now, patients or individuals with respiratory diseases, specifically those chronic conditions, will lead them to some sort of impairment. And that impairment not necessarily will limit them from doing physical activity or doing their daily life activity, but the symptoms that is associated with the disease itself is the one who leads people to get low physical activity and in general, a low functional ability in performing jobs. So it is not the disease. We all have symptoms. Most of us have diseases, but not necessarily would lead us to disability or those functional impairments, but rather the symptoms that is associated with the disease are the responsible or the govern for those type of things. So physically, individual face reduced lung function, that will lead to a decrease in quality of life and the risk of decreased longevity, which is the topic of the conference that we are talking in. Also, the psychological effects of the chronic diseases. The chronic nature of these conditions can lead to anxiety, lead to depression, leads to a different level of psychological events that people with chronic respiratory conditions or in general chronic condition will go through. So that should be taken into consideration when dealing with patients with chronic diseases. Also economically, and that is so obvious when we are talking, and that's basically at the governmental level where they and the health institutions themselves, they care mostly about the economics, not despite of the quality, but with the quality of care that should be delivered to the patients. And the direct cost of medical care and indirect cost from lost work productivity place a substantial burden on healthcare system and the society in general. So highlighting the global impact, the Forum of International Respiratory Societies calls for urgent action to address these challenges through improved care, prevention, and set forth policies that will mitigate, prevent those type of chronic conditions. Now we look at the chronic conditions, and every one of us have a different definition of what is the disability. But we lack the uniqueness or the unifying definition or defining or describing the disability or the trajectory disability. Now, one of the uses of the rehabilitation theories is to help people to understand the trajectory of disability. So in this slide, we're talking about one of the most common rehabilitation theory, which is Nagy model. And Nagy's model in general is talking to differentiate between active pathology, impairment, functional limitation, and disability, providing a framework to understand how chronic condition progress to the health impact. So make no mistakes, we could substitute the health impact by a different synonym, like disability, decreased quality of life. So it is based upon you what context that you would like to discuss about your topic. So in this model, if you look at the figure we included in this slide, it always starts with the pathology. And the active pathology may result from trauma, a degenerative disease process, or other etiologies. Now, the condition involves interruption of or interference with the normal process and the simultaneous efforts of the organism to regain a normal status. So the pathology in most of the cases, specifically the chronic conditions, would lead to some sort of impairment. And what we mean by the impairment is the loss or abnormality of the anatomical or physiological, mental or emotional nature. So both the pathology here, based on this figure, and the impairment would lead us to the functional limitation. So the functional limitation refers to the limitation at the level of the organism, as which lead to the restriction into the basic function or the basic utility of that system. Now, if we are talking about, and we're going to have an example of how the chronic condition progress to the health impact in the next slide, but now we're talking about the concept itself, the model itself, and also we should include not only the model when we consider the definition of the concept that starts with the pathology, but rather we need to look at the mediator and the moderator effect, in which the mediators and moderators play a crucial role in life, such as lifestyle, genetics, and environmental factors can influence the progression, highlighting the need for personalized approach management and, as we say, all things considered. So we should never look at the disease itself and say, this guy has this type of disease, he must end up with this type of disability. That's a foregone conclusion. Everything is considered in terms of the lifestyle, physical activity, mediators and moderators, and so forth. So for better understanding of what we are talking about right now, we would like to have an example of a study that we conducted with our research group. So chronic respiratory diseases such as asthma and COPD often serve as a nexus of complex web of related health conditions, and it doesn't come alone in most of the cases. So these respiratory illnesses can not only coexist but also exacerbate to other conditions or other chronic diseases like cardiovascular disorders, diabetes, and obesity. So the interconnection between that presents unique the challenges in the clinical management of patients' care. So we have an example here which this study demonstrates a significant link between asthma and the increased risk of developing obesity. So in most cases, chronic conditions, we look at it as it's going to lead you from a pathology to impairment to a functional limitation to a disability. But in most of the cases, that model will not end up being with the disability. It might lead to another chronic conditions, and this is the example that we are going to look at, in which the asthma as a disease, and we're talking about the asthmatic patients who are not having uncontrolled, uncontrolled asthma. Basically, this is who are we talking about, the population. Patients with asthma, they are classified or characterized as having an airway obstruction, because that is the nature of the disease itself. The airway obstruction mediated by the presence of fearness, of shortness of breath, and the medication of uses some sort of medication that will lead in nature to gain weight, such as using steroids, and also the diet regimen. So all collectively, with regards to the mediator, will lead, in addition to the airway obstruction, to reduce physical activity. And that was our conceptual framework, is that patients with asthma will have airway obstruction with the presence of the mediators, such as shortness of breath, medication, diet regimen, will lead them to reduce physical activity, and they will be obese afterwards. So the methods that we have used in the study, it's a cross-sectional study in which the data from more than 2,000 participants were analyzed, aged from between 25 and 74 years old. The outcomes of interest were the scores for the anthropometric markers, the obesity markers in specific, the BMI, the waist circumference, the hip circumference, and the waist to hip ratio in the 4 groups of participants, in which we selected 4 groups: smoker, non-smoker, non-asthma, smokers, asthma, and also the 4th group is a smoker and asthma. And we compare each group with the non-smoker and non-asthma. So what we look at compared to normal or non-smokers with no asthma, individual with asthma, smokers, and smoker with asthma were significantly associated with increase in the PMI. And the same thing is true with the other anthropometric markers that we included in our study, the waist circumference, hip circumference, and the waist to hip ratio. We got the same results. And after that, we concluded that, not concluded, but we found some association between the 2 variables, the asthma and the obesity. However, the results of this study must be interpreted with caution, since it's not a cause and effect type of a study. It is kind of giving us a glimpse of how uncontrolled asthmatic patients they are going to process to get obese or to get another chronic conditions. Now, the important question when we have a chronic disease, or to us as a rehabilitation clinicians, researchers, academicians, is to look at solutions at the end of the day. So diagnosing the problem, this is something that the clinicians are excel at. But what we should be looking at is to find strategies to solve those type of problems. And one of the rehabilitation theories, and this is the second rehabilitation theory that I have talked about in this lecture, in which the first one was the Nagy model of disability, which is the trajectory of the disability. The IOM is the opposite, okay, in which this model is particularly relevant for managing chronic respiratory diseases, advocating for interventions that enable patients to take an active role in their healthcare. So rather than looking at the disability as a one-directional, the IOM model, the Institute of Medicine model, they are looking at the problem and trying to find a solution. So they are looking at the health condition as a bidirectional, in which the health condition process, the pathology and the impairment could be reversed by applying the appropriate intervention, include the patients in the management, patient-centered healthcare, and so forth. I will go quick, Dr. Sami, for the last slide. So here, what we are proposing of our previous study, in which the uniqueness of this model is they always start with the no pathology. So it is not normal to start with pathology. We live in a life, we born with no pathology. So if we get a pathology such as asthma, with the presence of the three factors, the three mediators, dynamic hyperinflation, smoking, socioeconomic status, physiological factors, would lead us with presence of airway obstruction, we are proposing that they will have some sort of less physical activity that will lead them to the obesity. That was our original concept. However, by applying the IOM model, we would apply some sort of intervention such as medication, get those people well medicated. Also the education, providing them the education on how they control their asthma. Also promote exercise to increase their level of physical activity. And we believe that will mitigate or prevent the process into the getting obese when you are a patient with asthma. So the future recommendations is the future direction should focus on integrated care models that includes or encompass the multifaceted nature of chronic respiratory diseases. Also, the clinicians should adopt a holistic approach to patient care, incorporating evidence-based intervention that address both respiratory symptoms and associated conditions like obesity. Researchers are encouraged to explore innovative treatment modalities and the underlying mechanism linking respiratory condition with other chronic diseases. Also, the policymakers should advocate for healthcare reforms that support the comprehensive care strategy, aligning with the Saudi vision, with the great Saudi vision of 2030, to enhance the management of chronic diseases and improve patient outcomes. And thank you very much.
Thank you, Dr. Khalid. I think we need to move to the next speaker. So at the end of the session, we will have got your questions. Thank you, Dr. Khalid. Our next honorable speaker, Dr. Khalid Al-Rubi'an, full professor of endocrinology and internal medicine, currently working as the director of research and scientific center at Sultan bin Abdulaziz Humanitarian City. He's the chairman of board of trustee and founder of Diabetes Science International Foundation. He's the chief editor for International Journal of Diabetes Mellitus. Dr. Khalid, floor is yours.
Yeah. Assalamu alaikum, sabah al-khair. Bismillah wa salatu wassalamu ala rasulillah. In the beginning, I would like to thank the people who have organized this meeting for inviting me and also for choosing this topic. Let me tell you, I have worked in medicine since I joined the medical school now, almost half a millennium. I have spent 50 years of my life. I'm already 65, so I can tell you I have spent 50 years of my life in medicine. I have really touched this issue in a very, very practical way, in a way that I have seen my patients dying. When I was a medical student in the mid-70s, diabetic patient who will develop renal failure in Riyadh usually die within 3 months because there is no dialysis, there is no transplantation, there is no peritoneal dialysis. I have seen those patients either in University Hospital or in Shemesi Hospital. Over the last 50 years, I can tell you that there has been tremendous changes. And I'm really proud and happy that College of Allied Medicine have really chosen this topic, because I can tell you, and I can assure you, that the future for medicine is for rehab medicine. The humans are now aging, and I can see it in myself. The more you age, the more rehab you need. Now, let me go over the title, because the people who have chosen this title were so smart that, in fact, it is the time now to explore such things. What is longevity? Do we mean it is the lifespan humans can spend? Do we mean that it is the time when you are around and then you have to leave? Is it fixed? Can we change it? Is there a way to really modify longevity? This is what I'm going to answer in my presentation. But before I go into this, I would like to tell you, Jocelyn, from Jocelyn Clinic in the United States in 1950s, which is almost 70 years back, announced a medallia for any diabetic patient who proves that he have lived 50 years after he's been diagnosed with diabetes. At that time, they were only able to collect 338 patients only. This tells you how much medicine have really changed. I can tell you now, diabetic patients nowadays can live normal life and normal span. For that reason, I'll go into the next point, which is basically speaking about Hadith Nabi Sallallahu Alaihi Wasallam, that you are born with your age. There is no way you can change it. Now, if you are born with your age, this means that you could die before your expected time, but in fact, it is your age, whether you die by an accident, a disease, or by an old age. So keep this hadith in your mind when I'm talking, because I'm going to show you now what will happen with longevity. Is longevity, in fact, the amount of how much you can age? Is age, is the living time, and is living time material? Is time material? You know that with the quantum theory now, we believe that time is not is a material impact, and there I don't think I'll go into this details. But if you look on the left side, on the right side of the slide, you will see the data from the World Bank, which have been published only 2023. They have found that people will die because of accident, either car accident or accident at home or war or whatever. We have about 6.3% people dying because of accidents. Because of the disease, people usually touch 20%. What does this mean? That your chance of dying because of accident is around 6%, but you have 20% chance of dying because of a disease. But look at the majority. The majority are living long, and they die because of aging. So is aging a disease? Are we talking about something which slowly kills you? And this is why we go and we end our life. You have almost, I could say, 70% chance that with your age, you are going to finish. Nobody have really stayed long. And even if you speak about the age itself, we are materializing age based on the sunrise and sunset, the day and then the weeks and then the months and then the years and so on. Now imagine when I took my picture when I was 50 years old, which is 15 years back, my age on Earth was 50. But look at what will happen when you take me to Venus or Mercury. I'll be older. Now, if you take me away from the sun, I'll be younger and younger and younger. Does this mean that age vary when we move from one planet to another planet? Let me tell you, age is just like an elastic band. The more you stretch it, the longer you will live, but the more agony you will have. And this is what I'm going to show you. And I'm going to take diabetic patient as an example. Yes, we have made diabetic patient live longer, but do they have a better lifestyle? This is what I'm trying to answer today for you. Are we providing people with better quality of life when we subject them to longer or longevity? This is something you have to keep in mind as a medical person. But from a philosophical point of view, I can tell you, you are born with age, you will finish your age, and then you will die, either by an accident like I show you, or a disease, or because of your old age. Now, when you look at age from a medical perspective point of view, you will be shocked to see the guy on the right side, he's only 10 years old. And the guy on the left side is 26 years old. What does this mean? This means that what you can see from healthy, or the health definition, correlation to age, does not exist in medicine. And this is the molecular genetics and epigenetic factor. So those people who have that disease on the right side, usually they die when they are 15. When they are 15, they are equal to 90 years of age for normal people. While the guy on the left side usually also die early. They don't go beyond 40 years. This means that they have low longevity. Both of them have low longevity, but the other guy has a lot of medical and biomedical and genetic changes that have made them look old when you compare them to the one who's in the left. I want to break another news which is very interesting for you, and I'm sure some of you doesn't know this. If you are a woman who is 50 or 44 years old, don't think that your brain is the same age, or your stomach is the same age, and your kidney is the same age, and your liver is the same age. This is not true. And this is when we are looking into the molecular changes and metabolic changes. Look at how many organs in the woman older than their age versus how many organs in the men older than age. I think this is why when you look in any mortality studies, you'll discover that men usually die before women. They have the best hormones. We have the bad hormones. They have the best mechanism. But we have also somehow limited mechanism. And for that reason, so even when you look into the body itself, the age is different. And this is why when your kidney start to lose nephrons slowly, when you are 70, I can tell you that your kidney is almost only 30% functioning, but it is enough for you. Does this mean that when you are living longer, you need less of your lower functions of your organs? The answer is yes, it's true. So for that reason, this is why we have become weak and our activity is less, and we are the way we think is slow, and so on and so forth. So I love the theory of turtle. You know, the turtle it can live very long, but they are very slow, even in decision and in the movement. So this keeps also another issue. Does diabetic patients suffer from this also variations? The answer is yes. Very clearly, if you see a woman who is pregnant and she's diabetic for 10 years, believe me, medically, we treat her as if she is pregnant when she is 60 years old, if she is 40 years. So we add 20 years to her age, because this, we know this is the risk of her pregnancy. So it seems that this has to be also taken in consideration. When you go to the Guinness, those are, sorry, if you go to the record of Guinness, the two ladies you have seen are the highest lived in Earth according to the documentation, and strong documentation reported in the news and so on. So the Guinness, they only collected, I gave you the top 10. I'm sorry you cannot see the slide. But if you see the 10 people who have really break the record of Guinness, you will find that 80% of them are women and only 20% of men, for the same reason. It seems that longevity is something also correlating with gender, and gender does really have an effect, and also does really affect the outcome. I don't know if you can see the screen. No?
Got a small screen down there.
There are screens. Okay, we'll go. Then we'll move. I think we are losing everything. Let me tell you the story now. Now, I'll continue talking to you about the link between life or lifespan and the chronic diseases. And I'm very happy with our with Dr. Wadi when he really just showed you that although you may carry a disease and this will limit you, but we can really make your life easier and more practical. In fact, my next slide is just only showing you what happens in the globe when it comes to the mean lifespan. At age, but at least there is a shift on the right side for the curve. This is going to be on the expense. You have to pay more money for this. You have also to exert a lot of stress on the patient themselves. This is just to show you what is happening with different continents and the estimated lifespan. I just want to tell you that, again, look at the women are in a better shape than a man, even historically, going from 1970 until now. So it seems that gender is also showing this effect. I just made this slide, and then I would like to explain it to you, because this tells you the overall longevity observed in general population. Please note, I didn't touch diabetic yet, because I'm going to stress on diabetics after a while. Now, if you take us before 1900 almost, then the average age is 30, and the R square, which is the curve, is almost flat. There is no improvement for years and years and years. Now, between that point to the other point, which there is tremendous new drugs and new health system, look at how much we have improved. We gained 5 years, but look at the R square. This is what we call in statistics the takeoff point. This is the takeoff point where we are now reaching the huge changes. Imagine in almost 150 years, we have moved from average 30 years to 73 now, or 72. Can we do it for diabetic patients? This is what I'm going to try to really tell you. But before I go into this, I was also very pleased that the first speaker have really focused on obesity. In my personal opinion, the major problem of chronic diseases and the major factor that limit longevity, in my personal opinion, is obesity. And obesity is not a healthy sign, although Arabs consider it as a healthy sign. It is an inflammatory process. And there is a lot of changes in the body when you gain only 10% of your ideal body weight. I don't want to go. Look at this. If you are underweight, you will have very high mortality. This is what they call U-shaped curve. If you are underweight, you are going to have high mortality. Now, between the normal range of the BMI, we are okay. The mortality is look at how much you can really pick up or lift up your mortality in any given community by only exceeding 30, a BMI of 30. This tells us if you implement it in Saudi Arabia, believe me, almost more than 50% of our community in the uplifting in the right side of this curve, which is really something very bad, unfortunately. And this is not only diabetes, but also hypertension, hyperlipidemia, ischemic heart disease, and so on. Now, if you plot the countries and look into the lifespan and correlate it, you can see that the lower countries in the green in the Africa, and the highest is the orange and the purple in Europe and North America. Now, this means that there are still people who are having a lifespan less than 60, where we are really seeing a lot of problems there, medical problems, and they did not develop their health system in a way that they can pick up themselves. Those are the major deaths reported by many studies, and this is an cumulative data which I have gathered from the CDC. And this tells you that the cardiovascular disease is the main killer. The cancer is sharing, chronic kidney disease is sharing, and diabetes comes in the bottom. But I want to tell you, part of the kidney problem is also shared by the diabetes, and more than 40% of ischemic heart disease you see here are really diabetic patients, unfortunately. So if you ask me if diabetes is related directly or indirectly in the mortality, I can tell you in any given society, more than 50% of the mortality is really coming because of diabetes, unfortunately. And we are seeing it also in the kingdom here. This is just to take you very quickly on the gender effect, which I have already explained to you. And this is just to show you specific all cause and specific mortality. You can see that women are better than men, but also you look at the cardiovascular cancer and other diseases. The same observation, if you compare non-diabetic, consider them as number one, which is scoring one. Look at how much diabetic patients with age, they are really having the risk or the hazard ratio of dying because of the disease. Yeah. This is the same, showing exactly the survival rate, which I don't think I'm going to go into it. The same things observed in male and females in diabetic patients. And this is just only summarizing for you what would happen to non-diabetic versus diabetic when it comes to diabetes status and the mortality, whether you are more than 45 or your age is less, or your age is less than 45. This is including the disabilities, and this is what I want to tell you. We got our patients to live longer, but unfortunately, they are in agony, and we put them in more distress and disabilities. The same observation when you take diabetic and non-diabetics, and now you are looking into the different factors, you can see that diabetic patients are really outmosting all other diseases. I'm sure someone will speak to you about this recent review, which was published in Cell, and they have looked into all the metabolic changes that can affect the aging. I want to tell you from that circle, there is about 12 items which has been proven scientifically to really lead to aging of a human body. I want to tell you that all these factors are almost multiplied in diabetic patients. And this is why, unfortunately, they are also dying slowly and slowly. My slide before last is just to show you what is happening in Saudi Arabia in relation to obesity. You can see the two lines there, and you can see that obesity is increasing until a certain age, and then it's decreasing. Decreasing, I'm telling you, not because the obesity is decreasing, but because the obese people who are 10 years before have already died, and this is why what we call cohort effect, unfortunately. And this is a very important signal figure that tells you, look at, even if you see the different colors, I have made them to tell you why they die in the first stage, second stage, and also in the third stage. This is the mortality rate from diabetic patients in Saudi Arabia. I want to tell you, unfortunately, until this moment, we are losing almost 10% of our diabetic patients because of this complication and also the aging process. Unfortunately, this is my last slide, and this is one of my paints. I paint this paint, I think, almost 20 years back. When I was thinking about the process of life, you are born and then you become young and then you run in this life and then finally, slowly you sit in a chair and then after that you are below earth. Now, this is longevity. I want to tell you, this cycle is going to be quicker if you adopt obesity, especially with any comorbidities, diabetes, hypertension, or hyperlipidemia. And most of the killer or the most killing disease in such patients, in diabetic patients, unfortunately, is ischemic heart disease. And there is only one way you can improve this, by rehabilitation. And I want to tell you that we are running a study now on cardiac rehab in Sultan bin Abdulaziz Humanitarian City. And we have found that the people who have been subjected to cardiac rehab, they have lived longer by 7 years than the people who refused to go into the rehab. So thank you for all your program and thank you for this wonderful meeting. Assalamu alaikum.
Thank you, Dr. Khalid. It was a fascinating talk, Dr. Khalid, and we enjoyed it. Thank you. The next honorable speaker, Dr. Al-Habib Swalma, is a consultant image-guided neurosurgical navigation, head of neuronavigation and intraoperative surgical imaging unit at King Fahd Medical City. Dr. Swalma, floor is yours. You have got 20 minutes.
Assalamu alaikum. Good morning, ladies and gentlemen. So my presentation today is about image-guided neurosurgical navigation from pre-operative strategic planning to intraoperative accurate guidance. Also through this presentation, we will see how augmented and extended reality technology is helping to contributing in longevity by using a digital surgical infrastructure, which is addressing the threatening problem to surgically to remove the problem without inducing any undesired deficits, which will impact directly the quality of life. So living a long and fulfilling life has been always a supreme goal for humans. Over the last 2 centuries, lifespan and health span have been significantly enhanced and extended. The extended longevity has become a reality that is shifting us toward rethinking the future of healthcare. The assorted range of longevity solutions indicates that there is a shift away from the passive acceptance of aging as a norm to aging as an obstacle to overcome through using technological innovations. As we all know, neurosurgery is a high-tech profession. At least it has that cachet. Over the last few years, navigation has become a technology that continues to transform surgical intervention into safe and less invasive procedures. Among other medical technologies, neuronavigation is pushing the limits of conventional neurosurgery, enabling new and more precise procedures. It's unlocking a new broad neurosurgical horizon. What was a simple localization tool has become a centerpiece of technology in the OR. It's used as an information center to provide the surgical crew with the right information at the right time. So with the advance in computer technology and neuroimaging, neuronavigation is this platform which uses the neuroimaging data to preoperatively plan for the surgery, intraoperatively guide and assist the surgery, and nowadays with the advent of intraoperative imaging solutions, it is possible to assess the results of the surgery while the patient is still on the surgical table prior to close the skin. The following flowchart summarizes the infrastructure on which the neuronavigation is built. After being acquired, the imaging is pushed through the PACS system to the navigation planning station. At this stage, we start doing the processing, reconstructing the 3D object, extracting them, and any relevant information for the surgery. At this stage, putting all these 3D objects together, we ended having some sort of a virtual patient, the digital twin of the patient, the surgical digital twin of the patient. The imaging, the digital twin of the patient, along with the pre-surgical planning, are saved and pushed to the navigation platform inside the OR. At this stage, we are ready for the surgery. So digital twins are shaping, the digital technology of digital twins are shaping up in front of our eyes the future of healthcare. So we have a raft of use with this simple virtual replicas to a model which we can use to have exponential insights. The creation of closed reality patient model in the metaverse is allowing us to have a valuable immersive training and simulation opportunities, providing a safe and realistic environment for surgeons to enhance their skills and practice complex cases and improve their decision making. So as you can see here, one example of using that digital twin to go further and try to prospect more deeply the case by, in this case, we have a tumor and we want to see if there is any eloquent region around that lesion that we need to take care of during the removal of the tumor. So we're using here a TMS, transcranial magnetic stimulation, to see if there is any eloquent spot. All this information is saved and will be brought inside the OR the day of the surgery. So just to open a small bracket to show that the virtual reality along with the augmented reality and the mixture of the two and under the umbrella of the extended reality technology. So basically the virtual reality is entirely computer generated that used to do the surgical planning and understand the situation and what we're dealing with. Whether the augmented reality is a live view of the real scene, like for us, the surgical field, augmented with a digital information that we superimpose on the same environment. And we can see there we have a bounty of benefits related to this technology. So as I mentioned, since we have this surgical virtual patient, we can slice it, manipulate it, use it to do the surgical planning. So basically we ended having a precise information and precise idea about what we will be dealing with inside the operating room. And roadmaps are generated and saved, and they will be deployed at the right time inside the surgical field. Here I'm showing you just with the development of image processing and computer graphics, we get to that extent now where we have a very realistic representation of the brain and personalized models that depict the real anatomy of the patient. We can see the crisp of the cortex. We can see the venous anatomy. It's helping a lot to do that surgical planning and to plan the right way how to get to that problem and how to safely extract it. So as you can see, it's almost looking real, and these reconstructions are based only on neuroimaging data. Since we have also that model, that digital twin, we can go further and simulate and try to simulate the virtual craniotomy. We have a tumor case and we have an epilepsy case. So having such information, after having the results of the prospection, we can tailor the optimal opening around the region of interest, where to work comfortably and not jeopardize any other region of the brain. Here, another representation is another step. Now we have the availability of new and very advanced color maps that are giving the impression that it's true objects. So we can peel out all the anatomy of the patient. Like here, I can remove the vessels, the venous anatomy. I can remove the brain. I can have a close look on the tumor, which is localized in the temporal region, along with the ventricle. You can see all these color maps are so realistic today that are helping to understand the context of the problem we're dealing with. Also, there are very useful information. Like here we have the tractography, the tracks, where we can see the uncinate tracks in the temporal lobe, and we can see that instead of invading these tracks, the tumor is pushing them away, which means we can be aggressive with the tumor. Simply when we get to that extent where we are close to this fiber, we need to be more careful. Also, with the tools we have, we can crop the region of interest and play with it in space. So we can have a precise idea and see if there is any other better way to approach the problem. So the extended reality is that infrastructure that mingle the patient data and sync it to the real patient in the physical space, allowing immersive experience. The component of this platform starts with the cloud and edge computing solution, the Internet of Things, the artificial intelligence, the big data and analytics, and the 5G network, which is connecting these entities all together. Just to go quickly through these things, the cloud computing solution should be medically certified service along with the edge. The two things, because the edge is the same solution and is used in proximity of the place where the data is generated. Because for the time-sensitive information, when we can't afford any latency in the decision, in the information we're dealing with, we need to have a processor which is close by to deal with that data. This is taken care of with the edge computing. Also, we have the Internet of Things with the emergence of all these small group smart devices, like you have the sensors, the videos, and everything, and they are becoming so smart. We need to have a system that will process this information to extract the relevant information in a low latency processing to get the maximum of benefit from these information. Also, we have the artificial intelligence and machine learning algorithms that are running in the background to imitate the person and to get to the decision and related to specific situations. As all we know, all the artificial intelligence is integrated today in nearly all high-end technologies. Same thing with the big data analysis, where it's decrypting and processing the information to gain a new insight and make informed decision. While the 5G network is connecting and tying up all these components together. So you have here an image of the conventional operating room at the current state. As you can see, we have a plethora of monitors all around, and the surgeon, while he is operating and he needs to confirm his location or to get any information from the data available in the navigation, he needs to turn his gaze and look to the monitors, losing the surgical site in his field of view, and then go back. This is not good in a way that we need for hand and eye coordination. We need to have our hands in our field of view. This is what is taken care of with the new generation of navigation system, where we are using goggles head-mounted displays to inject that information in the view of the surgeon, and no need for him to turn his head while having that information, and we can choose the location where we can put. If we're using these goggles as a display, as a monitor, you can choose the way where to put this information, and it's close by, and no need for you to move away from the surgical site. So the location and this technology also, for another step, is bringing us to another level where if you are seeking any help, any from another surgeon elsewhere, the location is no longer a barrier, because that platform now is accessible, and you can share the information, and that expert can, through digital tools, provide usual instructions and drive effective collaboration. And the information provided with expertise can be shared over all the experiences. And the true power of this platform is to connect all these buildings and these capabilities to get from information to insight, from observing only things to understand what is behind. And the prospect of the next generation neural navigation system is to harness the power of this extended reality technology to build a system with a continuum that will involve in the planning, simulation, robotics, education, and training. And here you have just an example of the goggle we're using, the head-mounted display. These I tested them myself, and I did few flu planning with them, as you can see here. And what I did, I took my phone and I inserted inside one of the visors of the goggle, and I took this, because what you see is like inside the room, and you can see, like for this example, I have a skull along with vessels like the basilar artery and the tumor, and I was able to go inside the cranium, inside the foramen magnum, and rotate to see where the basilar in relation with the tumor. It was impressive, something really depicting the real state of the things and what we will be dealing with in the OR. This is the virtual reality. Now, this is an example of the augmented reality. If you remember, I said it's a real surgical field view augmented with a digital information. Here we have the microscope. A microscope is a tool that is used to magnify and shed light on the surgical field. This is a stable platform that can be co-registered to the navigation. So we can track the focal point of the microscope. Also, what we can do, we can inject these contours. You know, we save the road maps at the stage where we are planning. We save them. Here we can deploy them. Like for adding a contour around a lesion which is not seen with the naked eye, but that information is available in the imaging. So these contours are superimposed on the real view, injected in the head-up display of the microscope, and we can tailor the removing of this lesion. Also, you can see in this example of minimal access surgery, where we are going through transsphenoidal, transnasal through the nose to remove a small tumor, microadenoma of the pituitary tumor. As you can see, it's here, the yellow part, and using the augmented reality to have that best positioning of the head with the perfect corridor to get to that lesion, along with any information like the carotids. These are to avoid, and to know the exact location of that tumor during the removal of this microadenoma. So retractor is inserted, and then we can switch and we can go with the endoscope. Here are the carotids, the tumor, and the endoscope, and we can start opening the cella to get to the lesion. Also, what we can do, we can track any instrument in the surgical field in a case we want to get some guides during the surgery. In this case, okay, we have the tumor. There is a remnant. It was hidden. We did an intraoperative imaging. We outlined that tumor, and then we're going back, as I mentioned before, because we have that facility. We're not closing until we are satisfied with the result. So that small remnant was removed, and we closed the case. Here also, for this minimal access surgery, we have a selective case where we're doing temporal lobectomy. Instead of doing these big openings, today we are opening small opening because we have the technology that allow us to localize where we are. So you can see the opening is like the size of a dime, like $1, and we go through that opening. We can do some recording like electrocorticography to know exactly where the site of any epileptic activity. And after that, this information is available and we can use it at any time, deploy it in the surgical field. Here, for the temporal lobe disconnection, we can do it before getting inside the OR, during the pre-surgical planning, just to have the line near the central point behind the optic radiation to not have any problems with the patient. And as you can see, this information is used to guide the surgery. And as you can see here, we saved the optic radiation in the tractography. Also, we're using the simulator as a rehearsal practice tool to train core skills in a risk-free environment. So what you use to learn is what you operate with. Every touch is enhancing the skills of the surgeon. So what you plan for the operation is integrated to what you operate with. So information is optimized and customized. Here, quickly, we have a tumor in a very, very sensitive region in the thalamus, which is the gateway. Everything, all the fibers are going through the gateway. And we are planning here to get to that location to get a specimen without inducing any deficit. And we're using the DTI, the tractography, to see this. So we have a small clearance there. We went through the ventricle, where usually we don't want to go through the ventricle, but in this case, we went to the ventricle and we took that specimen. You can see the moving dot is depicting the actual position where we are. Now, after that, we go inside the ventricle and notice the tracks, the red marks are the fibers, and we are going in between because we have that small opening. We get inside the thalamus or the lesion, we took that specimen and we send it to the pathology. To get that level of accuracy, we use a robot. So in this case, we use the robot. Here we're just opening a twist drill opening, and we insert a biopsy needle. We took a specimen and we're out. So understanding the association between anatomy and imaging is a challenge, and neuronavigation is a possibility to bridge the gap between them. The patient, every patient brought to the surgery is a unique set of challenges based on different pathology types and location. The virtual reality and augmented virtual reality rehearsal, augmented reality guidance are assessing the anatomy and function of that particular patient at that particular, with that particular problem in that particular time to enhance the safety and effectiveness of the intervention. This is the essence of individualized medicine. With advanced technology, prolonging cognitive and physical function, age is less representative as a marker for lifespan and aptitude. So the unfolding of these events seems to corroborate the saying that age is just a number. Thank you very much.
Thank you, Dr. Habib. It was an excellent presentation. Our next is honorable speaker, Dr. Namish Modi. Dr. Modi is a senior lecturer and research group leader in the Aberdeen Cardiovascular and Diabetes Center. He got his PhD from in biochemistry from University of Dundee. His research of interest and expertise is nutrition, obesity, and metabolic. Dr. Modi, floor is yours. You have got 20 minutes. Try your best to be on time, please.
Okay, thank you very much. Welcome to all of you that have come this morning. Thank you for coming, and thank you to the organizing committee for inviting me to this wonderful conference or this fantastic venue. So we've heard a lot about all these health conditions that accompany us in longevity and aging. In particular, we've heard about chronic diseases such as obesity and diabetes, especially this morning. So I'm going to tell you about some of the molecular pathways that are involved in these diseases and how, by investigating these pathways, we can find new strategies to improve health. So we know that the rates of obesity are increasing globally, especially in the developed countries, and also developing countries are increasing the rates of obesity in both adults and also children. So this is very disturbing. But obesity is linked to many diseases, and most associated with type 2 diabetes. Through this condition, insulin resistance, which is a precursor to developing full diabetes. But it doesn't just end there, because insulin resistance is accompanied by many other processes: dyslipidemia, hyperglycemia, oxidative stress, ER stress, and inflammation are all involved in the pathology of these diseases, not just type 2 diabetes, but comorbidities of hypertension, cardiovascular disease, diabetic kidney, steatotic or fatty liver, and even in some cases, cancer. And normally we would control these in the clinic. We've heard about some of the treatments that are involved. If they cannot be controlled by lifestyle changes and medications, then of course this will lead to severe complications and ultimately death. So what do we know about the processes that go on in these? So we know that obesity is controlled by a hormone called leptin, which is released from the adipose tissue, from the white cells, white adipocytes of the adipose. And this works in the brain, in the region called the hypothalamus, to control food intake and energy expenditure. But also we know that glucose is controlled primarily by insulin. So glucose uptake is controlled into skeletal muscle and adipose tissue. It's promoted through the glucose transporter GLUT4, and insulin shuts down hepatic glucose production in the liver, which is up in the fasted state before you feed again. But now we know there are many other factors that are released from adipose tissue that also contribute to the regulation of glucose and the action of insulin in the rest of the body. So this is the connection from adipose tissue to systemic glucose control and insulin action. So some of these are metabolites, such as free fatty acids and lipids, but some others are cytokines, which are involved in inflammation in the body. One hormone, adiponectin, is an insulin sensitizer. So if its levels increase, that's actually good for you. One that I'm going to focus on a little bit this morning is RBP4, retinol binding protein 4. So what we found in research almost 20 years ago now was that retinol binding 4, which is the sole carrier for retinol, which is vitamin A, is increased in mouse models of high-fat diet-induced obesity, and also genetic model of obesity, which both of these models, when you induce the obesity, it causes diabetes as well. So you can see here in the control mice, there is a low level of RBP4, but it's increased in high-fat diet and in the OB genetic model of obesity. And further studies also confirm that RBP4 was upregulated in humans, both men and women, and different ethnicities across the world had increased RBP4 in the serum, and this was linked to obesity-induced insulin resistance and the progression to type 2 diabetes. So we were interested that with this hormone being regulated, being increased in these disease states, could we find a drug that could decrease this protein? And we found in the literature that in a breast cancer study with this drug, fenretinide, a synthetic retinoid, these patients suffered from a side effect where they had decreased retinol in their serum. And the reason for this decrease was a decrease in the protein RBP4. So we used this experimentally, and we found that if we incorporated fenretinide into the high-fat diet, you could decrease retinol binding protein levels. So here you can see normal mice have a normal high level of RBP4, but with high-fat diet is increased as they have obesity. But with fenretinide in the diet, you can normalize the retinol binding protein in the serum. So having confirmed that it lowered RBP4, we also then found that it had many beneficial effects. So fenretinide, you can see in this obesity study incorporated with high-fat diet, in normal mice eating chow, you can see that the body weight is maintained around 30 grams, but on a high-fat diet, it increases almost double to over 40 grams over a 20-week period. But with fenretinide in the diet, you can see that it's inhibited significantly. And this is accompanied by improvement in glucose homeostasis and insulin action, and also inhibits fatty liver disease. So all of the complications that I have described earlier. So through several studies published over several years, we were able to find that not only did fenretinide have an effect to decrease retinol binding protein 4, it also decreased leptin, which is the hormone released from adipose tissue, ceramides, which are involved in insulin resistance, and also another metabolic regulator, FGF21, which is secreted from the liver. And then we focused a little bit more on this in another mouse model, the LDL receptor mouse model, which is a model of atherosclerosis. Normal mice don't develop atherosclerosis, so we have to have this genetic model, the LDL receptor knockout. Here again, we were able to show that fenretinide treatment improved the fatty liver phenotype. You can see on a high-fat diet, those white globules are fat deposits in the liver. But with fenretinide treatment, there's a huge decrease in that fat in the liver. However, there was a bad side to fenretinide treatment. You can see here that with high-fat diet in the LDL receptor knockout mice, they have increased atherosclerosis in the aortic blood vessel with the plaque area that's increased there. But with fenretinide treatment, there was a detrimental effect of increasing the atherosclerosis even further. So we were then able to perform lipid analysis and find that there was increased ceramides in the serum of these mice, and that was the reason for the increase in atherosclerosis. So ceramides have been measured both in mice and in humans and are linked to cardiovascular disease. So that is the mechanism of this increased atherosclerosis due to fenretinide treatment. So far, I've given you an overview of the treatment with this experimental drug, fenretinide. It's not in clinical use, although it's still in clinical trials for treatment with breast cancer with new formulations. And so the research that we've done is very important in giving information to those studies. And what we found is that it can prevent high-fat diet-induced obesity and insulin resistance, and using multiple techniques, both mouse models and cells, and using omics techniques to measure lipids and also gene expression through RNA sequencing, we found the mechanism of action of fenretinide. But more recently, and what I'm going to talk about in the last part of my talk, is through the RNA sequencing, we've been able to find new targets in the liver of fatty liver disease. And some of the key drivers, and one that I will talk about is HSD17B13. So the disease I'm going to talk about is non-alcoholic fatty liver disease. Has been recently renamed metabolic dysfunction associated steatotic liver disease because it's associated with all these diseases that I've talked to you about, as obesity and type 2 diabetes. It's associated with obesity and is described as the excessive buildup of fat in the liver. It affects 25 to 40% of adults globally. So again, you can see it mirrors the massive increase in obesity and type 2 diabetes. There is no direct therapeutic target for this disease. The only thing that's prescribed at the moment is lifestyle changes. And it's also a progressive disease. So you can see in this schematic, in a healthy liver, there's less than 5% fat in hepatocytes, the cells of the liver. But with steatosis or increased fat in the liver, this increase above 5%, this is still reversible at this stage. But if the damage increases, the steatosis increases, there's also inflammation, ballooning, and fibrosis, and this becomes more difficult to reverse because it can then progress to cirrhosis in late stages of fibrosis and also hepatocellular carcinoma in some few cases. In both of these late stages, liver transplant or death is the only solution, and therefore understanding the processes that underlie the progression of the disease is very important. So when we did the RNA-seq in mice that had obesity and fatty liver, we identified several protein genes that could be key regulators of fatty liver disease. Many of these had been studied before. So you can see here the increase with high-fat diet of these genes such as MOGAT1, VNN1, VLDR. They've been studied by many laboratories around the world, the knockouts and inhibitors of these genes. So we went further down the list and found more novel genes that we didn't know much about, such as HSD17B13. And we also compared this to bioinformatic data that had been released by other labs. So we heard about this yesterday by Professor Asim Al-Fada, lots of bioinformatic analysis of omics data and human genomic data to try to understand the pathways that are involved in different diseases. So first of all, we were able to find with fenretinide treatment that we'd been using before, the increase in HSD17B13 could be reversed with fenretinide treatment as expected, both the mRNA and protein levels. But what do we know about HSD17B13? Why are we interested in it? So it's a novel lipid droplet protein that has been identified in human fatty liver biopsies. Its expression is limited to the liver and hepatocytes. So when we study it, we know that it's involved just in liver biology. And more interestingly, in human genetic studies, SNP variants that generate loss of function protein. So that protein doesn't function as well as the normal protein is associated with protection from liver injury. So that's very interesting. However, the labs in the US, two separate labs that studied the knockout of HSD17B13, it should be protective against developing fatty liver disease, was not protective. So this was an interesting finding that was a bit disappointing. So we took a different approach and used a new technology called RNAi therapeutics. So here we took mice and put them on a high-fat diet. They became obese and developed fatty liver. And then we injected them with shRNA to knock down the levels of HSD17B13. So here you can see this was successful with the obesity and high-fat diet. There was an increase in HSD17B13. And when we used the shRNA to knock down this gene, we could knock it down successfully. And it had a beneficial phenotype as well. So here you see shRNA knockdown of HSD17B13 inhibits fatty liver disease. Here you can see the high-fat diet scrambled control has these large lipid droplets, the white droplets that you can see, and these disappear with the HSD treatment. Serum ALT activity is also used in humans to monitor liver health. You can see it's increased with high-fat diet obesity, but decreased with HSD RNA knockdown. So overall, we know that shRNA knockdown of HSD17B13 inhibits genes involved in hepatic lipid metabolism. The pro-fibrotic progression to NASH is also inhibited, so that's very good, but it had no effect on body weight, adiposity, or glucose homeostasis. So it's a very specific effect in the liver. Finally, we did a lipidomic analysis to understand, again, the mechanism of this action, and we found that diacylglycerols, which are increased and contribute to disease, are decreased with the knockdown of this gene, and phospholipids, which are decreased in disease, are now back to a healthy level. And these phospholipids are long-chain polyunsaturated fatty acids, so that's good. And now we are ongoing studies to elucidate the gene expression changes associated with these specific lipid changes to understand the molecular action of this knockdown and this gene. But why is this important, and why are we studying this gene? Is it got any therapeutic potential? Yes, there are companies that are involved in RNAi therapeutics, collaborating with larger pharmaceutical companies and doing several clinical trials. So Arrowhead with GSK, Regeneron and Alnylam, Ionis with AstraZeneca are involved in clinical trials, and they've passed phase 1 clinical trials. So they're doing more investigations in phase 2. So they're showing promising results, and we may see this in the future. And so I just want to acknowledge the people that have done the work, my PhD students at the University of Aberdeen, in the Aberdeen Cardiovascular Center, my collaboration with Mirela Delibegovic and her laboratory, lipidomic analysis by Phil Whitfield at the University of Highlands and Islands, and now at the University of Glasgow, and my former PhD students. Okay, thank you very much.
Thank you, Dr. Namish, for being on time. Thank you. You can. Our next honorable speaker and the last speaker in our session today, Dr. Saad Al-Hammad. Dr. Hammad is assistant professor in the Rehab Science Department at College of Applied Medical Sciences at King Saud University. His expertise area, clinical exercise physiology and cardiopulmonary rehabilitation. Dr. Hammad, it is your floor. You have got 20 minutes. Please try your best to be on time. Thank you.
السلام عليكم ورحمة الله وبركاته. حياكم الله جميعا حضورنا الكريم ومتابعي البث عبر قناة الجامعة. Good morning, everyone. I'm pleased here to be at the 3rd International Conference of CAM, and I wanted to extend my gratitude to the organizer and the scientific committee for their hard work and preparation in making this event possible. Today, I have the honor to discuss a topic that holds a great significance: the relationship between physical activity and longevity. Physical activity, whether through exercise, sports, daily movement, plays a vital role in promoting longevity and improving quality of life. Scientific evidence supports the positive effects of regular physical activity in reducing the risk of chronic diseases and enhancing mental well-being. During this presentation, we will explore the impact of NCDs, the non-communicable diseases, on mortality rates, and discuss the key risk factors associated with these diseases. Then we will explore the alarming statistics that highlight the growing prevalence of physical activity within the globe and within Saudi Arabia. I will also highlight a new player in the game, a condition that may impact the physical functioning even in the middle-aged population. Before I finish, I want to highlight also the 2020 WHO guidelines on the PA antidentary behavior for older adults, and finally presenting a new simple tool that has the potential to predict the mortality. Recent data reveals a significant increase in the number of deaths caused by NCDs. The WHO estimated that in 2008, cardiovascular diseases, cancer, COPD, diabetes caused this number. Within 10 years, these numbers has increased to 41 millions. A large volume of research has clearly shown that physical inactivity impacts additional non-communicable diseases. Beyond these elements, physical inactivity is responsible for up to 8% of deaths and non-communicable diseases that are attributable to physically inactive. So what are the modifiable risk factors within the behavioral that influence these NCDs? Tobacco use, unhealthy diet, alcohol use, and physical inactivity. To keep these individual physically fit, at 7 a.m. on the White House lawn, and you can read the quote, "We paid no attention to the weather except for a very heavy rain." They also played in cold and wind, snow and rain. Dr. Bone invented this game, and you can notice how heavy the ball is. It weighs around 3 kilograms. And most of the physical therapists here are familiar with this ball, which is called Hoover ball. It was named after President Hoover in the White House, and he said about this game, it requires less skill than tennis, was faster and more vigorous, and therefore gave more exercise in short time. So that ball was named after him, and for the history freaks like me, this is the first telephone to sit on the desk of president. And the Hoover also, if you are familiar with Hoover Dam in Vegas, it was also named for his contribution there. So Dr. Bone actually invented this game for the president and his office co-workers to keep him really active and to achieve good health outcomes. So let's explore the global to local mapping physical activity levels. This is a very well-known paper in the Lancet journal that shows different physical inactivity in age groups by the WHO region, which is from America, Africa, Eastern Mediterranean, Europe, South Asia, and Western Pacific. And you can see people over 60 are reaching high or large bars there from 50 to 60% of the inactive adults. What about Saudi Arabia? Saudi Arabia is at an early stage in its demographic transition to an aging population. So diabetes incidence increased by 94%, cardiovascular diseases by 54%, cancer by 50%, which may lead to higher health and economic burden. A recent review provided a comprehensive assessment of recent studies reporting on physical activity and sedentary behavior and the correlate of those behavior in Saudi Arabia. The review included 6 databases and focused on higher quality studies by including only those using population-based sample. And only one study included strength and balance in their intervention, which was done by Osama and colleagues. High proportion of the Saudi Arabian population doesn't meet physical activity recommendations, and we will also go with these recommendations, and spends many hours daily in sedentary behavior. So this is from the Authority of Statistics أو الهيئة العامة للإحصاء بحسب توصيات منظمة الصحة العالمية, or based on the WHO recommendation, only 29% of the population is involved in 150 minutes of exercise. Based on the quality of life program, almost 50% of the population are engaged in 30 minutes of exercise during a week. So, and this was better than the data presented in 2019, which was only 20% instead of 29.7%. So I need to put that arrows to just highlight this tiny bar actually from the that demonstrate the total population. And you can see now the difference also between the male and female who engaged in physical activity. And the blue bar also highlights the high amount, which is 79.7, which is almost 80% of the population from the female are not engaged in physical activity and maintaining a sedentary behavior. So that also let us do a larger project, and partially I'm presenting this paper which we published with our group, physical activity levels among undergraduate students at the College of Applied Medical Sciences, King Saud University, Riyadh, a prevalence study. So we enrolled 377 students in our cross-sectional questionnaire-based survey that was conducted between March and May 2023 among undergraduate male and female students who were randomly selected from the various departments within camps. This study was also approved from the IRB, and the physical activity was assessed using the physical activity questionnaire GPAC. The average survey response rate was 89.3%. So these are the different programs who responded from the camps. As you can see, different students are also engaged in vigorous intensity activity, which lasts for 1 hour per week. And the most reason they reported for not engaging in physical inactivity is lack of time, then unwillingness to do a physical activity. Also, that was in reverse within the Saudi population that was reported from the General Authority of Statistics. 40% of the population were unwilling to do physical activity or engaged in physical activity. A new player that I said also may affect the physical activity. In a paper that led by Dr. Aid Al-Ahmari and colleagues, including Dr. Khalid Al-Wadi and myself, we did this long-term effect of COVID-19 on pulmonary status and quality of life. An individual with a history of probable or confirmed the infection, usually 3 months from the onset of COVID-19, with symptoms that last for at least 2 months and cannot be explained by an alternative diagnosis. This is the definition of long-term COVID. A recent systematic review reported that 63% of people who are infected by this virus had at least one type of COVID-19 consequences at 6 to 12 months followed up after recovery or discharge. And almost 60% of the patients continued to suffer at 12 months follow-up and above. This observational study aimed to assess the lung function, exercise capacity, and health-related quality of life in post-COVID-19 subjects after 1 year. So we have 2 groups, one case group who are infected and they maintain 1 or more symptoms of long COVID, and control group who never has been diagnosed, and that was confirmed by the Saudi registry also. Their age was almost 32 years old. They have similar BMI, and some of them were hospitalized. So the distance walk, there was no significant differences. However, there is a trend to lower walking distance in the case group. Also, the Borg scale dyspnea post-walk median was significant difference between the 2 groups. We also use the 6-minute walking test and the SF36 control. And you can see the differences between the case and control group in terms of 3 domains, which are the energy fatigue, the emotional well-being and general health being, and also physical functioning. There was a significant differences between the case and control group. So higher amounts of sedentary behavior are associated with all-cause mortality, cardiovascular disease mortality, cancer mortality, incidence of CVD, and type 2 diabetes. So 4 to 5 million deaths could be averted annually. Literature also confirmed that sufficient levels of physical activity can in part treat or prevent NCDs, improving associated risk factors, decrease the incidence of disease and mortality rate, and reduce the national care cost. So what are the WHO guidelines? So if I ask you, do you meet the WHO recommendation for physical activity? All adults should undertake regular exercise activity or physical activity. Adults should be at least 150 to 300 minutes of moderate intensity aerobic physical activity, or at least 75 to 150 minutes vigorous intensity aerobic activity. For additional health benefits, on at least 2 days a week, muscle strengthening activities at moderate or greater intensity that involve all major muscle or group. Also, more than 300 minutes or more than 150 minutes of vigorous intensity aerobic physical activity is recommended for additional health benefits. For the older adults, they also recommended to do additional 2 days a week of muscle strengthening activities at moderate or greater intensity, and on at least 3 days varied multi-component physical activity that emphasizes the functional balance and strength training at moderate or greater intensity. Is there an easy test to implement, simple to score, and has a decent predictive capabilities? The one-leg stand test as a predictor of mortality that was published in the British Journal of Sports Medicine last year, and the anthropometric clinical and vital status and 10 seconds one-leg stand data were assessed in 1702 individuals between 2008 and 2020. About 20 of people in their 60s were unable to do it. By age 71 to 75 years, that numbers has increased to 50%. So they were unable to do it just 20 years from their cohorts. Upon reaching their 80s, the number of individuals unable to perform it rises to close to 90%. It's easy to do. So people in their 60s, they are most likely to be in the unable to complete the test, and this increases within 5 years. The participants in the age group 71 to 75 years were more than 11 times more likely to be a non-responder as compared with those just 20 years younger and belonging to the youngest age group in the study. Middle age and older participants unable to complete it had a lower survival over a median of 7 years compared with those able to complete the test, within an 84% higher risk of all-cause mortality, even when other potentially confounding variables or risk factors were taken into account, such as age and comorbidities. Some local initiatives that I would like to share, inspiring the active lifestyles. For example, امشي 30 المسار رياضي sports boulevards and sports for all رياضة الجميع. These are national strategy recommends the lowering the proportion of people with low physical activity. Also, we have done the marathon, and I know most of you participated in it. As I heard from the leaders and the dean, she wants to keep it a ritual before every conference, inshallah. Also, leading by examples, His Excellency Dr. Tawfiq Al-Rabi'a keep publishing about his physical activity, and he keep maintaining more than 10,000 steps. And I would like to quote his one of his quotation from last book, الوقوف على أطراف الأصابع، ذكرياتي مع جائحة كورونا 2020. ومن تلك الأشياء التي لم أتركها أبدا لا في سفر ولا في حضر المشي لأكثر من 10,000 خطوة. كنت أستغل لحظة المكالمات أو تلك اللحظات التي أحتاج فيها لتفكير مركز أيا كان المبرر. هي عادة لم أتركها في حلي وترحالي، حتى أذكر أنني في بعض المرات أعود من السفر متعبا ولم أكن وقتها استكملت حصة المشي، فأخرج قبل أن أستريح لأكمل تلك الخطوات. Finally, I would like to acknowledge all the participants and volunteers in our studies, my esteemed co-authors and research partners, CAMS leaders and the Dean, who are also facilitating our research and encouraging us and giving us opportunities to present this work, our RHS administrative and teaching staff, also my dream teams from the students who I really enjoyed working with, and thank you very much.
Thank you, Dr. Thank you, Dr. Saad. It was an excellent presentation and we enjoyed it. So now I would like to invite all of our honorable speakers to come up to the stage. One question for each speaker. Any question for the speakers? We have got 3 minutes for questioning, if you have questions. Otherwise, we might end the session of this morning. It seems there is no question, so I think we gonna end the session. I would like to thank our honorable speaker for their fantastic presentation. It was an excellent contribution. Thank you. And I think we have got a trophy for you. ولا لا شباب؟ Yeah.
I think we have.
نبني البيت ما يحتاج. It seems we don't have that question, so we will leave. Thank you.
Thank you very much. Thank you.
شكرا.
هذا
السلام عليكم، صباح الخير. خلال 5 دقائق سنبدأ الجلسة التالية.
السلام عليكم ورحمة الله وبركاته. صباح الخير جميعا. بعون الله نبدأ جلستنا الثانية لهذا الصباح بعنوان تحسين فترة الحياة الصحية، مواجهة التحديات الحسية والتواصلية لدى كبار السن من السكان المسنين. Good morning everyone. We will start our second session for this morning, titled Optimizing Health Span, Addressing Sensory and Communication Challenges in Aging Population. Our first speaker this morning is Dr. Brahim Al-Faraj. Brahim is a clinician and an audiology researcher. He earned his PhD from the University of Manchester. He also was awarded the British Academy of Audiology Conference in 2021 and 2022, as well as the University of Manchester Outstanding Achievement Award in 2018. Dr. Ibrahim, the floor is yours.
Thank you, ladies and gentlemen. Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you, Dr. Abdurrahman, for your kind introduction. Thank you all for joining me today for my presentation. Today, I will talk about, do we need audiogram-based prescription for successful hearing aid fitting? For successful hearing aid fittings. But before I dive into my presentation, I would like to present some facts about hearing loss. So more than 1.5 million people around the globe have hearing loss or some degree of hearing loss, meaning that 1 in 5 have some degree of hearing loss. Around 1/3 of those individuals have disabling hearing loss that requires hearing healthcare or medical attention. These figures are projected to increase or to gradually increase over the years, resulting in 2.5 billion individuals with hearing loss and 700 million individuals with disabling hearing loss by 2050. Hearing loss can result in communication difficulties, leading to difficulties in engaging in meaningful conversations in easy and challenging listening environments. Untreated hearing loss can lead to many negative consequences, including depression, social isolation, and anxiety, low quality of life, low education attainment, and also unemployment. Presbycusis or age-related hearing loss is a common condition that affects many people as they grow older, with 1 in 4 of individuals aged over 60 have disabling hearing loss. The typical hearing aid programming process involves comprehensive hearing assessment to measure the lowest threshold or the lowest tone a person can hear. After doing or completing the hearing assessment, we transfer the hearing thresholds to a computer software to quantify or predict the amplification characteristics of the hearing aid. And after that, we transfer the amplification characteristics to the hearing aid, and then we measure the amplification characteristics using a proper microphone system next to the eardrum to ensure that the person receives the optimal amount of amplification. The demand for affordable and easy accessible hearing aids has urged researchers, developers, and policymakers to begin exploring and authorizing alternative hearing aid delivery models and devices. This include self-fittings devices and pre-programmed devices. Now, what we asked in our research is that, do we need audiogram-based prescription to program hearing aids for adults, or we can use any of the alternative hearing aid delivery models or devices? So what we did is that we developed a systematic review protocol, and then we pre-registered the protocol in the International Prospect Register of Systematic Reviews, PROSPERO. Then we published the protocol in British Medical Journal. In our eligibility criteria, we said we will include any studies that compared any alternative hearing aid programming method with best practice. And then we set up our eligibility criteria also to include only adults with any type and degree of hearing loss. In terms of search strategy, we developed our search strategy using control terms and free text words, and we searched 8 different databases. In terms of the selection process, 2 independent reviewers screened the identified records against the inclusion criteria. In terms of quality appraisal, we used Downs and Black checklist to assess the methodological quality of the identified studies, and then we used GRADE tool to assess the overall quality of evidence. What we found is that we found 7 studies, and we grouped them under 3 categories. The comparative fitting approach, where the researchers or the audiologists use their knowledge and experience to fit hearing aids without relying on the results of the hearing assessment. And the second category was predefined frequency responses, which means that the researchers will ask their subjects to self-select one of the available sets of pre-programmed hearing aids. And the third category was self-fitting, where the researchers ask their participants to self-fit themselves at home without any assistance using their smartphones. In terms of the comparative fitting procedure, when the researchers compared this alternative fitting approach with best practice, they found that self-reported listening ability was similar between the 2 conditions, the alternative fitting condition and the best practice. The difference between the 2 fitting approaches, the best practice and the comparative fitting procedure, was not statistically significant in terms of speech intelligibility in quiet. In terms of speech intelligibility in noise, however, there was a statistical significant advantage in favor of the best clinical practice. For the next category, which is predefined frequency responses, where researchers compared pre-programmed hearing devices with clinical best practice. They compared these 2 approaches using 5 different outcomes, and the figure here shows the effect size and positive values indicate an advantage for the alternative hearing aid fitting approach, and negative values indicate an advantage for the best clinical practice or prescription approach. As you can see here, hearing-related quality of life was significantly better with the best clinical practice. And in terms of self-reported listening ability, it was also significantly better with the best clinical practice. But for the remaining outcomes, the difference was not statistically significant between the two fitting approaches. For the third alternative fitting approach, which is self-fitting, researchers compared the two fitting approaches using 5 or 4 different outcomes. And again, here, as you can see, the figure shows the effect size. Positive values indicates an advantage for the alternative fitting approach, and here it is self-fitting, and negative values indicate an advantage for the prescription approach or best clinical practice. As you can see here, listening preference was statistically better with the alternative fitting approach, which was not expected. And in terms of self-reported listening ability, the difference was not statistically significant between the two fitting approaches. And in terms of speech intelligibility and noise, the difference was also not statistically significant between the two fitting approaches. And sound quality was again better with the alternative fitting approach, which was also against our expectation. So what these findings mean is that the interpretation depends on the comparator and the outcome. Small number of studies and quality of evidence was generally low because of many factors, including lack of blinding, lack of randomization, lack of concealment, and so on. For two comparison, statistical significant difference or advantage was in favor of the best clinical practice or prescription method, but the advantage was unclear if it is meaningful to patients or not. And self-fitting has potential to provide equivalent or better outcomes and potentially lower cost. So final observation, quality of evidence, not as high as we might think. We always have a small number of studies and risk of bias frequently high. And there is no agreement in terms of on outcome domains tools to use, meaning that different studies use different outcomes, limiting our ability to compare them in a meta-analysis. And we also have little knowledge on minimal important difference, so that if any of the identified statistical significant advantages, we don't know whether it is of clinical value or not. That's bring me to the end of my presentation. I would like to acknowledge Kingston University, and also would like to acknowledge also NIHR Manchester Biomedical Research Center for their support and co-funding my PhD. Thank you.
Thank you very much, Dr. Ibrahim, and thank you for sticking for time. Our next speaker this morning is Dr. Manal Al-Harbi. Dr. Manal. Dr. Manal will present on a talk, A Clearer Path, Optometry Journey in Enhancing Elderly Life. Dr. Manal, تفضل.
بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. Good morning, everyone. We all know that knowledge and awareness are playing a very important role in managing geriatric cases, along with screening programs. But our problem is that we always targeting those population in their community, like geriatric clubs, geriatric center, where most of the people gathered there, they are in their 60s during their retirement period. That is not bad, because at least if there is any damage, we are preventing a further damage. But the more proactive approach is reaching those patients and educate them in a younger age when there is no harm. So we can prevent the harm rather than approach it when it's happened. And this is exactly what optometrists can do easily. And when I say easily, because the first aging changes happen in the eye very early, around 40 years old. And the good thing is that this is not a silent change. Like, you know that most of the changes are silent during aging, but this is symptomatic, interfere with the daily activity of the patients and bring them to your clinic. And here our role in improving the quality of life of those patients starts. So if we, being able to discover any problem they have, we can effectively manage their ocular problem. Also, some systemic disease showed their early sign in the eye, where the patient sometimes doesn't know that he have this systemic disease and discover it for the first time in the eye clinic. So by doing that, we can help the patient and we can contribute to the overall well-being of those population. To know more about that, let me take you to our journey in enhancing elderly's life. So since we talked about, I can use this. Since we talked at the beginning about the knowledge and awareness of the people about their problems, let's see what is the knowledge of our population about the ocular disease. We can see from this study that done in Saudi Arabia in 2019 that the knowledge and awareness of cataract, diabetic retinopathy, and glaucoma are good, compared to a poor knowledge about age-related macular degeneration. And this can be explained because the first three diseases are more common in Saudi Arabia, while age-related macular degeneration is not common, because actually it's also more common in lightly pigmented eye, which is not common here. But from this study, we can tell that we still need more knowledge, more awareness about the age-related problem that can happen in the eye. Which part of the eye going through changes? All these structures of the eye, from the front until the back, going through changes. Some changes are actually, most of the changes affect the appearance with a seldom effect on the performance. Some external appearance that we can see on geriatric patient, that the eyes looks a little bit in, which we call it an enophthalmos. And that's due to a loss of fat of the orbit. And it's not effect on the patient, it's just an appearance. And also the lid looks drop a little bit because the orbicularis oculi muscle weaken. So if it does not interfere with the visual axis of the patient, it won't affect them. Before we go to the structure of the eye, there is an important layer covering the anterior part of the eye, which is the tear film. And many patients, old patients, have a problem with the dryness. And usually, in general, dryness means not enough tear or the tear evaporated very quickly. And usually, which is a quantity or a quality problem. And usually with old people, it's a quantity problem. And it is, as we said, more in old people who's using contact lens and more in women than men. Treatment by using an artificial tear, we always recommend using a non-preservative natural tear and ointment. Ointment on bedtime is very good because it gives a good lubricant to the eye during sleep. Starting with the first structure, which is the cornea, we always see in old people a white ring around their cornea, which is a deposit located within the peripheral stroma. And this is just a structural change that will not interfere with their vision. And it's called an corneal arcus or arcus senile. Although it could be a sign of a high cholesterol. So we need to exclude this diagnosis before, differential diagnosis before we confirm it's arcus senile. So we need to send the patient to the family medicine to do a lab result and just be sure that there is no high cholesterol, because it could be the two problems together, a structural change on top of high cholesterol. So the other changes is the change in the curvature of the cornea, which may cause astigmatism. And that's what makes some patients start to use glasses for distant just when they get old, because astigmatism affects on near and distant vision. And we have to tell the patient that this is not a serious thing and it will not deteriorate their vision. It is something that can be easily corrected by glasses. Lens changes include a change in the size and thickness and elasticity. And actually the elasticity problem, along with the weakening of the ciliary muscle that hold the lens with zonules, is what caused the problem that I talked about in my introduction that will bring the patient to your clinic at age 40, which is a presbyopia. This makes the patient not able to read materials well, and they can't continue like this. They need help. So after doing a comprehensive examination, we can discuss the choices with the patient. We always would like to preserve the accommodation. So we ask the patient to try to deny, increase the light, and we always encourage the 20-20 rule, which means 20 seconds of a break every 20 minutes of reading time, looking for something 20 feet away. If this didn't work, this means the patient needs help, so we can go with reading glasses. If he's having a distant and near, we can use a bifocal or a progressive. A progressive cosmetically better, but it's a little bit challenging. What about contact lens? Since they have a dry eye, so contact lens is not the best solution, but it's still a possible solution. We have to put on our mind that being happy with the way you look is part of your quality of life. So even if it is for cosmetic and glasses is better, is still an option. And we have to sit and listen to the patient and put all the possible choices without harming. So we always listen to the patient and make them comfortable without harming. So the option could be a bifocal contact lens. If somebody a little bit older or not moving or some other problems, they can use a monovision. Use one eye for distant and the other for reading. Another problem related or changes related to the lens is a cataract, which is the obesity of the lens that more one of the age-related problem, and also can happen in patients with diabetes, smoking, and exposure with a lot of exposure to the sunlight. So you can imagine if all these factors together comes in one person. This means he may have cataract more than others. So this is, again, the awareness and knowledge is important. So if the patient avoid most of the risk factors, that will give him less chance to have cataract, for example. Surgical management is the best solution. And actually, before they were waiting until the cataract become mature, which is a little bit not good for the quality of life of those patients, because they almost become legally blind before they extract the lens. And you can imagine all these years without being able to see well. Nowadays, with the phaco technique, the patient can do the surgery while he is still able to see. Vitreous, which fill the big part of the eye, is a gel-like with a high viscosity. With age, it's become more liquefied. This liquefaction makes the cells and organic clusters to float freely within the vitreous. The patient will perceive these as spots or fibrous strand floating in his visual field. This is harmless, and we always ask the patient to ignore it, and with time they start to ignore it. But we should not ignore that this could be a sign of a serious problem called the posterior vitreous detachment. So we also need to exclude this before we go and say this is a normal changes. Some age changing in performance, the contrast usually decrease after age 50, and a glare also due to all the lens and vitreous humor changes that we discuss can be a problem for the patients. Age-related macular degeneration, the disease I told you that we need to make more awareness about for our population, is a degenerative disease caused the loss of the center vision due to a destroy of the macular area. And you can see how the patient with age macular degeneration see things. It's related to age, and as we get older, the chances of developing age macular degeneration increase. The risk factor, as I said in the beginning, it's more likely pigmented eye, people with a family history of age macular degeneration, smokers, obese, and people above 65, and again, like a dryness, more in women than men. According to the age-related eye disease study, the treatment could include special vitamins, mineral supplement formation, laser surgery, eye injections, and photodynamic therapy. When we say a low vision, here we have a patient with visual impairment. Here we can't help the patient with eyeglasses. We can't help them by contact lens, medication, or surgery. And this can interfere with their daily activity. This can happen due to an ocular disease that cannot be treated anymore, or due to a birth defect or eye injury. Those patients can get the benefit of using low vision aids like a telescope lenses, some software for computers, and more devices. We have many of the devices that can help the patient. What is the sign of systemic disease in the eye? There is many, actually, like 20 diseases that can be discovered, but I'm giving just an example. For example, if we look at the back of the eye and found swelling of the optic nerve there near that arrow, and change in the size of the pupil, loss of the side vision, patient having a recent double vision, all these things tell us that the patient may have a brain tumor. Also, if we see on the fundus, tiny blood vessel leaking the yellow fluid or blood, this means that the patient may have diabetic retinopathy, and referring the patient to the endocrinologist going to change his life. High blood pressure could be seen as an unusual bend or bleeding from blood vessels that we see in the retina. Also, referring the patient to the cardiologist will make a big change in his life. What is the frequency of ocular examination? American Academy of Ophthalmology recommend that patient, as we said, have a comprehensive baseline examination at age 40. And then between 40 to 54, they should be examined every 2 to 4 years. Between 55 to 64 should be examined every 1 to 3 years, and 65 and above need to be seen every 1 to 2 years. What is the sign of emergency? What is the sign that make us tell the patient you need to go for emergency help if you have those symptoms? A sudden blindness or see many new flutters. We said the flutters is common for old people, but if suddenly they're becoming many, this may be a sign of something serious. Having eye pain, experience double vision, having redness or swelling of your eyes or eyelid. All of these things should bring the patient to the emergency room. So our role as an optometry doctor, as a primary eye care provider, to make a good educational support and increase the awareness of people, do screening program and targeting all the population, not only the geriatric population. Many of us having elderly people in their home. So for me, being young and be able to know what is the sign that should make me take the person to the emergency make very different, and the quality of life of the elderly person who live with you. Also, you will know what you have to prepare yourself for when you become old, so you can avoid many risk factors and prevent many diseases from happening. Comprehensive eye examination on a regular basis to detect and manage cases timely. Here, I'm just giving a little bit of tips that can help the patient to deal with aging eye. American Association of Retired Persons recommend that people supposed to keep using sunglasses to protect their eyes from UV radiation. Stop smoking. Healthy food include high vitamins A, C, E, and minerals like zinc and omega-3. These vitamins could help, and minerals could help to prevent the occurrence of age macular degeneration, for example. Physically being active and maintain a healthy weight, maintain normal blood pressure, maintain normal blood sugar, and home modification is very important. You know that falls among elderly is what all health discipline try to avoid. And lose of vision or poor vision is one of the main reason for that, and one of the main predictor factor for that. So by making some modification like installing a hand drills, eliminating trip hazard, no need to have a lot of decoration in a home that have an elderly person, especially if they're using a wheelchair. Brightening the light, improve the contrast, like having a white wall with a very dark light switch that will be improving the contrast and help them to see. And it will be much better if we can have a motion light to create a senior friendly living space. Actually, a motion light means it will open by itself if anyone enters the room. That's perfect choice for the elderly people. Write with bold and newspaper with a bold line to help them write in a straight line. And sometimes there is like a strong A4 paper with a line holes that can be put on top of the paper and they can write inside. That will help them also to write in a straight line. Use a clock with a large number and phone with a large screen. Finally, we all excited about the bright future of 2030. So let's save the vision of our elderlies so we can all enjoy this wonderful vision of Saudi Arabia. Thank you.
Thank you very much, Dr. Manal, for this very thorough talk. Our next speaker is yet another expert in optometry. Please join me to welcome Dr. Mat'ab Al-Anazi, who is an assistant professor in the Department of Optometry at CAMS KSU.
Thank you, Dr. Abdurrahman. Assalamu alaikum wa rahmatullahi wa barakatuh. Today, I would like to thank the College of Applied Medical Sciences for organizing this wonderful event. And today, I'm delighted to share with you this topic for the next 20 minutes. I'm going to be talking about managing diabetes and hypertension for vision wellness in aging population. To begin with, we live in a country or region where we facing a higher, or the highest, I would say, one of the highest populations of that has a highest prevalence of diabetes in the world. Several studies have shown that the prevalence of diabetes that could range from 20% to 25%, which is considered to be very high, which means 1 out of 4 individuals in Saudi Arabia have diabetes. Hypertension, on the other hand, have less prevalence. As you can see here in the map, and it's about 9%, which can vary from one region to another. I'm going to focus on the impact of these conditions, systemic condition on vision. And for diabetes, it can have several impacts on vision, starting with diabetic retinopathy, which we deal a lot with in the eye clinics, macular edema as well, cataracts, glaucoma, and also retinal detachment. Also, in general, the patients have increased risk of infections, change in refraction, where we face a lot also in the clinic when the patient have their, let's say their blood sugar level is not being controlled. So the diabetic retinopathy, I'm going to focus more on this complication that comes with diabetes. It's closely related with the duration of diabetes, which means the patient, when they have a diabetes that's not under control for a longer time, they are at high risk of developing diabetic retinopathy. Based on the studies that shows the retinopathy is expected in 20% of the patient, with diabetic patients, after 10 years, and 80% after 20 years. This tend to affect more females than male. 5 to 10% of patients have develop advanced sight-threatening retinopathy. There are differences between type 1 and type 2 in the term of the development of diabetic retinopathy. There are risk factors. The main risk factor is the duration of diabetes. There are other risk factors as well, such as smoking and hypertension. There are studies. This is one of the studies that monitored the patients diabetic patients and also monitor their A1C level. If you can see here on the graph on the right side, if the patient has a level of A1C level of 7% or less, they are less likely or uncommon to develop diabetic retinopathy. Each 1% decrease in A1C reduced the diabetic retinopathy development by 37%, which is very important to monitor. I came across this study which showed the importance of patient education. This study was conducted, I would say, a couple of years ago on about 350 patients. Those patients specifically developed advanced diabetic retinopathy. And the second thing, those patients never had an eye exam before. So they showed up on the clinic and they have these complications, very advanced complications. What caught my attention in this study, when they asked them, they surveyed those 350 patients, is when they asked them, why didn't you come earlier for the eye exam? The most common answer was because they didn't know what's the next step, which is closely related to patient education. The second most important, or the second most reported answer was because they thought the visual loss was related to age and it's normal. Those 2 points, they are very closely related to patient education and can be avoided with providing the proper education. And here are the other reasons as well. When they asked them why didn't they do the annual eye exams, and again, the lack of knowledge scores the most. The impact of diabetic retinopathy in the quality of life could be summarized in 4 points. Causing visual impairments, the patient will have, if they're not treated, they will lead to vision loss. Patient will go through emotional and psychological effects, also impact their quality of life. Limitation and independence. The patient will be dependent on others to do their daily tasks. And we are talking about if they've developed diabetes, for example, vision loss and becoming low vision patients. In this case, will have this issue. Also, the systemic conditions such as diabetes will have complications that are not only within the eye, but also could affect the cardiovascular, kidneys, nerve damage in the body, and also that will lead to impact the longevity and the quality of life. For hypertension, it also has an impact on vision. We're talking about the hypertensive retinopathy, retinal vein occlusions, choroidopathy, optic neuropathy, and macular edema. When we talk about treatment, we also talk about the socioeconomic burden of diabetic retinopathy. This is one, keep in mind, this is only one complication with diabetes that's within the eye. The most important one is the healthcare cost, and also the loss in productivity. The patients who are diabetic and develop these conditions, they need to go to hospitals, they lose, and the effect from diabetes, they're gonna affect their productivity as well. There's a disability and rehabilitation. psychosocial impact, educational challenges. This is an image from the OCT, which is an optical coherence tomography, shows a cross-sectional part of the retina, which is the central part. You can see this is abnormal. Those diabetic patients have accumulated fluid within the retinal tissue, which impact their vision. The reason I'm showing this, because one of the treatment is to inject the eye directly with what we call the anti-VEGF to stop this fluids from accumulation and bring back the retina to the normal shape. And also the anti-VEGF is used for new vascularization. And with these two complications, when we use anti-VEGF, it's directly injected into the vitreous. It has complications and it's very expensive. And the patient needs to have several doses of these anti-VEGF to get the efficacy of the treatment. And we're talking about each dose costs between $1,800 to $2,500. The complication also involves the infection, inflammatory reaction, retinal detachment, hemorrhages, and traumatic cataracts. The second treatment here is the pan-retinal photocoagulation. Is another part of the treatment where you use the laser to target those areas of new vascularization to stop them from growing even further within the retina because they're abnormal. Also, they come with complications. They're listed here. They can be very significant. Just keep in mind, these treatments are targeted for patients who have advanced diabetic retinopathy. How are we going to stop this from happening? It's a long way, but also it has to go through steps. For example, patient education needs to be provided properly. Healthy habits, promoting healthy habits, access to resources, implementing policies that supporting vision and wellness could prevent this from reaching to this stage. Here in the healthcare system, or as individual or healthcare provider, healthcare system in Saudi Arabia, we face several challenges at different levels. For example, at the level of individual, we might see the patients who have lack of awareness or lack of knowledge, which can be a limitation in this case. Financial limitations could prevent patients from getting the service, the healthcare, lifestyle factors as well. Barriers from at the level of the healthcare provider. We're talking about limited knowledge within the specialists, the lack of communication or inadequate communication. Some patients, they've been diagnosed with diabetes, and after the diagnosis, they're not referred for an annual eye exam, which could prevent a lot of things from happening, or at least delay them. Time limits, challenges in implementing evidence-based guidelines. At the healthcare system of Saudi Arabia, we know we rely on the free healthcare system, which is great. But at the same time, we face a lot of challenges with this healthcare system, which is the long wait and limited access. And also, if we look at the services being provided in Riyadh region, it's we have all the specialists here, very experienced professionals. But if you go to the north side of Saudi Arabia, you can see the difference in limited resources that could impact the quality or the providing the services for patients in other areas of the kingdom. Here I'm going to just show you pictures of fundus images of the retina. So this one is taken with a device. It's a camera. So you take it without touching the patient. It's very quick, very easy. And you can see the back of the eye. So on the right side, that's the circles, the optic nerve head. You can see the blood vessels. And for diabetic retinopathy, you can actually easily see those white spots, which is a characteristics for or features for diabetic retinopathy, and also the hemorrhages. Here's another example. Also with hypertensive, there are characteristics or features that we look at when we diagnose with hypertensive retinopathy. Hemorrhages, spots that actually very specific to these conditions. The reason I'm showing these pictures or these images to you, because there have been several attempts internationally and also locally about developing an AI tool for screening. This could be very beneficial for us here in Saudi Arabia, since we have the higher number of diabetic patients. The AI go through steps. The first step would require data collection, which is in this case, could be any data collection that makes sense. In this case, because it's easy to do and easy to obtain, is the retinal images. Going to be retinal images, the collection, the type of data. Then after that, after we collect the data, we have specialists and professionals trained to identify and label those images according to the case. And then we have pre-processing. Maybe we do some changes on the image to enhance the quality of the image. Then we extract those features within the image to see, for example, diabetic retinopathy, what type of hemorrhage are we looking for, the spots, and everything that we look at, and we tell the AI these features. Then we do training. This is very, very quickly, very simple. And validation and testing, that what we do, we check for specificity and sensitivity to see if the tool is effective as a screening tool. And then we do the continuous improvement for that. The reason I'm mentioning this could be a very effective. There are several attempts internationally. If you look at this table, you have, for example, the fourth row, or the column, sorry, it's the data set for development. You can see how many images they have collected in each study. Some of them, they exceeded 100,000 images. And with that, each image is labeled and linked to a patient. And then with that, the AI will learn. And we can see the AUC sensitivity and specificity for each device. And the numbers are very good and promising. And with that, we can have this tool implemented, and in the healthcare centers, they're not here in the center or in the major cities, to help us pick up those patients who have diabetic retinopathy and have them checked and referred. So the take-home message here, the lack of patient knowledge in the healthcare system issues contribute to the delayed diagnosis and the management of diabetic retinopathy. Diabetic retinopathy, it's preventable and can be easily delayed if treated on time, if they provide the patient education. The socioeconomic and healthcare system factors pose barriers to improving the diabetic retinopathy outcome. There are limitations, as we discussed, they're at the individual level, healthcare provider, healthcare system as well. Delays occur at various stages of healthcare, from symptoms reporting to ophthalmologist evaluation. The current treatment carry a significant socioeconomic burden. We saw how one of the complications that being treated with, and imagine you have a higher number of those patients that need that kind of treatment. Patient education and improved access to facilities are very important in this case. We need to have, I think there are attempts here in Saudi Arabia where you have where you have the AI tool as a screening. And if we have this implemented in the right locations, we can benefit from them. And we need to also activate what we call the telemedicine, which act to improve the patient education and awareness, especially on those regions of Saudi Arabia. And these are some references, and thank you all for being here. And if you have any questions, you can ask at the end of the session. Thanks.
Thank you, Dr. Mut'ab, for this enlightening talk on vision wellness for the elderly. Our next and last speaker for this morning session is Dr. Ala Al-Khatib. Dr. Ala Al-Khatib will talk to us on dental and oral health care. Dr. Ala Al-Khatib is an assistant professor at the Department of Dental Health Sciences at King Saud University. Dr. Ala, you may proceed.
Assalamu alaikum wa rahmatullah. Good morning, everyone. Thank you so much for being here at this morning session. I'm excited. I'm Ala Al-Khatib. I'm an assistant professor at the Department of Dental Health Sciences. I'm excited to share with you some observations from the literature on the importance of optimal oral health for healthy aging. This is actually one of the research tracks that we are following to understand who's the most at risk for oral diseases among us to generate knowledge needed to inform dental clinical care for the most vulnerable groups in our society. And hopefully through this research, we can be part of achieving Vision 2030 of increasing life expectancy and improving quality of life. So my presentation will focus on the prevalence of oral diseases in aging adults. What's the extent of oral diseases on the general health and well-being of this age group. I will conclude my presentation by discussing what we can do to improve the current situation and ensure better oral health for aging adults. So when we look at the prevalence of oral diseases, we can see that globally, oral diseases combined are one of the most common diseases. It impacts half of the global population. The burden of oral diseases actually exceeds the burden of other non-communicable diseases, including cardiovascular, pulmonary, diabetes, cancers, and mental disorders. So the previous slide showed the global burden of oral diseases combined. And when we look at the single disease level, we can see that by far untreated dental caries is the most common oral disease. It impacts 1/3 of the global population. Severe periodontitis or chronic gum inflammation is another common oral disease. It impacts around 500 million individuals globally. Tooth loss is a clinical outcome of severe periodontitis, and it impacts around 300 million individuals. These numbers are in terms of prevalence of oral diseases at the whole adult population globally, and it is consistent for aging adults. And when we refer to aging adults, we're referring to those ages 65 years and older. And for this age group, the main oral diseases that can cause disability, periodontitis, and edentism. In this age group, we also see increase in risk of oral cancer and conditions like xerostomia. I want to highlight that not only the prevalence of oral diseases that can go up with age, but also oral health disparities. As you can see in this graph, in the UK, throughout the last couple of decades, adults or older adults from low socioeconomic status are more likely to experience edentism throughout their lives compared to those from a higher socioeconomic status. So we know that oral health disparities exist in all age groups. However, it is more likely to strengthen for older adults because of the accumulation of risk factors for oral disease and the determinants of health disparities strengthen with age. So I hope I have convinced you so far that oral diseases are prevalent and have a global burden. I want to focus now on why we strive to ensure optimal oral health for aging adults. First, there is a complex pathophysiological interconnection between oral health and systemic health, with high quality evidence supporting associations between chronic diseases and oral health status. So good oral health, better systemic health outcomes. Second, oral diseases cause disability, and it is a financial burden on both individual and government levels. And particularly at national level, ensuring optimal oral health for aging adult is a critical component actually of ensuring achieving Vision 2030 health-related goals that include increasing life expectancy and improving quality of life. So poor oral health, particularly periodontitis or chronic gum inflammation, has detrimental impact on several organ systems. These include cardiovascular, endocrine, and pulmonary. And this can be explained physiologically by the increase in inflammation, or the presence of inflammation in the mouth will contribute to low-grade inflammation in the body. And with advancing in age, this can contribute to increased risk for these chronic diseases. Oral diseases are a leading cause of disability, and this can be quantified as disability adjusted life years, which is a measure of the overall burden of oral diseases. It is the sum of years lost due to premature mortality and loss of productivity due to a disease. Globally, it is estimated that we lose around 17 million years of healthy adult life due to oral diseases. And as I mentioned, the main causes of disability related to oral diseases are periodontitis and edentalism. This graph shows the extent of disability caused by oral diseases globally. And per the WHO estimate, here in Saudi Arabia, for every 1,000 individuals, we lose around 3 years of healthy adult life due to oral diseases. As I mentioned, oral diseases cost money, and unfortunately, we don't have exact numbers here at a national level on how much we spent on dental care. However, when we look at international numbers, we can see that in countries like the UK, they spent around £90 billion per year on dental care. In the US, it is estimated to be around 130 billion per year. And usually this cost combine both the actual cost of dental care and the expected loss of productivity due to oral disease. So this is to highlight that taking care of oral health is a good investment, not only at a health level, but also at economical level, especially when we think about oral diseases are preventable diseases, which makes these costs unnecessary. So what we can do to tackle all of these challenges related to the oral health of aging population, at a national level, we need population level comprehensive screening studies of oral disease prevalence and the impact of oral diseases. In dentistry, we need to shift our healthcare model from intervention-based to prevention-based and adopt a holistic approach of evaluating the determinant of oral health for our patient population. We also can help our aging adults in healthcare by integrating dental care with the routine medical care that they receive. This can be at primary care level or more specialized care. Here in Saudi Arabia, we have the infrastructure to achieve this. Almost in all healthcare settings, we have dental clinics. However, we need health services intervention to integrate dental care with medical care. This can be at appointment scheduling level or health education provided by medical personnel. So in conclusion, this presentation is just to highlight that by taking care of oral health, we're improving general health outcomes, we're minimizing health disparities, minimizing health-related costs, and being part of achieving Vision 2030 goals of improving quality of life, increasing life expectancy. With that, these are my main references, and I would like to thank the College of Applied Medical Sciences for this opportunity. Thank you for listening, and the organizers and volunteers.
Thank you, Dr. Ala, for this intriguing talk on addressing oral health for healthy aging. Now, allow me to welcome all of our speakers for this session for a final Q&A and to honor all the speakers. حياكم الله جميعا. Once again, I'd like to see if any of the audience have any question for our speakers this morning. If you do, please go forward to present a question. If you don't, I would like to address the general questions for our panel. Oh, please go ahead, Professor.
Thank you very much for the presentations. I enjoyed all of them. Dr. Ibrahim, your presentation was very good, and you did a systematic review. You didn't. I was wondering, your conclusion, you spoke about quality of the studies. Did you do a quality assessment as part of your process, your systematic review? Before coming to the analysis, before extracting data, did you do a quality analysis? That's my question. Is it clear? Okay.
Thank you. Yes, we actually, as I mentioned in my methodology slide, we did two. Yes, we performed two quality assessments, one for methodological quality for each individual study, and we used down and black checklist for that. And we also did an overall quality assessment using a grade tool before forming our analysis, before forming our conclusion. I didn't hear your question.
The quality tool was very good.
Yes.
You should have sorted out all the weak quality studies. So by the time you come to your analysis, you'll have good quality. Then you would not have a comment on weak quality studies. That was my concern.
So your concern is that why we included low quality studies in the...
No. My point was the quality assessment is a stage of the systematic review process.
Yes.
After you've done it and you have your criteria, you should have thrown out the weak ones and then analyze the strong ones. So at the end of your study, your results, you will not complain again about poor quality studies. That was my concern. Thank you very much.
Thank you. If we do this procedure, or basically try to exclude low quality studies, we will end up with one or two studies. In our profession in audiology, we lack, high quality studies, not only in this review, in most of the reviews in audiology. So we need to include these studies, and we need to acknowledge the weakness so that we can address it in the future.
Thank you very much.
You're welcome.
Thank you. I have one final questions for our speakers, those in optometry. With all the issues you addressed and the challenges that face elderly population, and specifically in Saudi Arabia, how do you propose to integrate optometry in primary healthcare in Saudi Arabia?
I mentioned some of these things during the presentation, like having more screening program, tele programs, mobile car, for example, all these things can let us find, we search for, we go for patients. And again, awareness and knowledge is playing a very important role. We need to have more educational programs to let the whole population know about the problems. I think the main problem and the main challenge that we think that we have to educate the old people about their problems, while we have to educate the young people about all the bad behaviors that they're doing, and they don't know that it will affect on their quality of life when they get older. So increase the awareness with a lot of screening everywhere, not in a geriatric center. Go to malls with the mobile cars and discover these cases and catch them timely and refer them properly to the specialties they need, depend on their cases. That's going to make a big improve and jump on the quality of life of those patients, I think.
Thank you, Dr. Mehta.
I think the first step need to be having optometrists have job opportunities in the primary healthcare centers in the kingdom. We have, I believe, hundreds, could be thousands of them across the country. Right now, the optometry graduates, I think that we have now 3 universities that have this program. We do have a higher number of them graduating every year. They are well qualified. The standards for like teaching them, training them, they're very more than qualified to work on these places. I think the need with the increase in population that we've seen across along the recent years, we're going to reach to the point where we have to face the problem. We have to have those centers work, and we have those optometrists work, because at least to detect these cases, provide the primary care services for them. And I think the optometry departments here at Kingston University, all the optometry departments in other universities are working. Also, every year we have recommendations that comes from the International Conference of the Saudi Society of Optometry. Always the first recommendation to allow optometrists to work at the primary healthcare centers. This can lift a lot of the issues, a lot of the heavy weight on the major hospitals, ophthalmologists. Let's face it, we have a less number of ophthalmologists. In order to have the number increase significantly to face the demand that we need, it's going to be a long time. And with optometry is a shorter program. The students or the graduates are well qualified. They have all the knowledge, all the clinical training that they need. I think this is the first step, and I'm very sure within the next couple of years it's going to happen. How it's going to happen, I don't know. We still kind of fighting for that, and I hope that we win.
Let's be hopeful for that. My final question is for Dr. Ala. If you may address our audience, mostly our students and graduates in dental sciences, a message for the future, how to address patient education to mitigate diseases in the elderly in order to have an impact on the economic burden of oral care for the elderly. Thank you.
Yeah, as you mentioned, I mean, throughout the presentations this morning, we all the time come back to patients' education, and this speaks to how powerful is the message that any of us as a healthcare provider provide to the patients. In dentistry, unfortunately, we're still we're evolving, but we have laser focus on intervention, just treating what's happening in the mouth. As I mentioned in my presentation, we need to take a holistic approach on evaluating the determinant of oral health. People can come from different situations that can impact their oral health, whether it's they're experiencing chronic diseases from a very young age, taking medication from a very young age. I think at dental students level education, improving our dental education system, and also integrating. I come back to integrating dental clinic or dental care with the medical care, because that's the gap is real between the two specialty. And when the patients, especially older adults, receive dental education from their medical provider, they will take it maybe more seriously than a dentist in a clinic. So, our research projects is starting to screen the impact or like the opinion of healthcare provider, and just to take the buy-in from the medical side to work with us in education. So we have a long way to go, but hopefully we'll be there.
Thank you very much. Dr. Baja.
Thank you very much for all presenters. Anyway, I have just reached the last two calls. My main question is regarding the AI, the new venue. It's the first time I heard in this conference in our college. So I heard it with Dr. Mutab. He mentioned it. I think it's the same for all programs, for all departments. And AI. The question is there any ready AI box template that student or any practitioner or any optometrist or in oral or in any different department in our college can use it and can collect the data, input the data, labels, all the images, whatever, and it just making a learning to the box, so it is available for everybody. In this case, it will be very, very advancing whatever cares, eye care or oral care or any subject. So this is one question. The second question goes to the Dr. Ala. Regarding, I think there is what we call a cross-linking between all cares, oral or eye care, whatever. I think the eye care, the eye health is also interested by the oral care. I think there are some infections in oral care. If it's not treated, priorly, may go to the next organs, and one of the important organs in human is the eye. Because I heard, it is very rare, some blindness may come out from oral diseases. This is my question. Thank you.
Thank you. I think about your question. Unfortunately, I'm not very experienced. I'm not in the field for like AI, but it has to start with an idea. Developing a screening tool, for example, with the diabetic retinopathy. Having the idea, you have to have a test or type of data that's easily obtained. For example, an image. And then with that, you can develop how from an image you can reach to let's say an initial diagnosis. It has to start with an idea within the optometry profession. I think we have a lot of ideas that we do a lot of screening, and we can develop a tool like that. We need to have someone experienced from the computer science departments, then they can help us with developing this. And I don't have exact answer for your question, but I think it starts with an idea, and then you look for wherever you need to go in order to have this idea tested and implemented eventually. I hope I answer your question.
Thank you, Dr. Mata. Thank you.
Yeah, the connection between oral health and systemic health in general is very complex. And eye health and oral health, it's not only about the physical proximity between the eye and the mouth, but also when we look at chronic diseases like diabetes, it has both impact on the eye health and oral health. And I will come back to the importance of primary care provider of addressing whether the complications outside of the systemic health with the patient, and also encourage them to see specialists regarding to this. So it is a very complex connections, but it's there, and we're obligated to address that.
Thank you, Dr. Ala. With that, we will conclude our session for this morning. And my final message is that with these bright minds, for the smart minds of the young and the youngest, we will achieve our vision 2030 and beyond. Thank you very much. Thank you, everyone. Dr. Manal, please, we'll be honored.
Now we will have the break up to 1 o'clock. Just want to announce that تكريم اللجان والأندية الطلابية راح يكون 12:30 إن شاء الله بإذن الله.
الحمد لله، كيف الحال؟ الله يعافيكم يا رب. ان شاء الله نبدا واحده ها؟
يكون كلنا عندنا
اوكي، هو احنا اول سيشن بعدها صح؟
إيه.
مين اللي
يكون في تكريم 12 وبعدين صار صعب
ولا مودريتور؟
إيه.
حلو.
لا افرح
انا عارفه بس
يا ابو مسكين لا
ان شاء الله في احد بصحته.
لا ان شاء الله عليك قبلك
ثلاثه يعني متى كنا معاكم؟
انا ودي ندرس هنا يعني اول نكون موجودين
خلاص بجلس هنا واذا بدت بجيكم. اذا بدي اشوف الحين الله يعطيك العافيه. ايوه سأل.
بس ما تحاول طيب امورك طيب من اليوم يدور عليك بيدور عليك طيب ما تقنع الدكتور
عايز
السلام عليكم، سعد الله مساكم بكل خير. أرجو من الجميع يعني أخذ مقاعدهم، إن شاء الله راح نبدأ دقيقتين. ودي إنه العاملين في اللجان يقربون شوي، يعني ما ودنا أن يكونون بعيدين عشان يطلعوا على المسرح مجموعات، فكرما منكم أنكم تكونون قريبين.
الحضور الكرام، نستعرض لكم عرض مرئي للماراثون المصاحب لمؤتمر كلية علوم الطبية التطبيقية الدولي الثالث.
كلية العلوم الطبية اليوم بماراثون تدشين مؤتمر الكلية الثالث عن مستقبل الرعاية الصحية وتحسين الأمر الصحي ونمط الحياة الذي يحسن الصحة ويحسن مستواها.
السلام عليكم ورحمة الله. أنا الحمد لله توفقت إني أفوز في الماراثون، والماراثون كان صعب والحمد لله توفقت وما قصروا والله كلهم. يعطيكم العافية على التنظيم الحلو وما قصرتوا، شكرا. إن شاء الله نشارك منظمات كثيرة بعد قدام إن شاء الله، ما حد قصر معنا أكيد، ويعطيكم العافية.
الآن مع تكريم الفائزين بالماراثون والأندية الطلابية والجمعيات المشاركة بالمؤتمر واللجان المشاركة، فليتفضل راعي الحفل للتكريم. تكريم الفائزين بماراثون كلية علوم الطبية التطبيقية الدولي الثالث. في المركز الأول الأستاذ نوح عبده. وفي المركز الثاني الأستاذ بدر الرحيمي. وفي المركز الثالث الأستاذ فارس الشمهاني. أما الآن تكريم الأندية الطلابية المشاركة بالمؤتمر. نادي دكتور البصريات. نادي صحة الأسنان. نادي التثقيف الصحي. نادي التغذية. نادي المختبرات. نادي الكلية الطبية الحيوية. نادي الأشعة. نادي العلاج الطبيعي. نادي العلاج الوظيفي. نادي العلاج التنفسي. نادي علل النطق والسمع. النادي الثقافي الاجتماعي بكلية العلوم الطبية التطبيقية. نادي طباعة ثلاثية الأبعاد. نادي التمريض، النادي الثقافي لكلية الصيدلة، تكريم وحدة الأنشطة الطلابية بقيادة الدكتور مسعد العنزي، تكريم الجمعيات المشاركة، الجمعية السعودية للتثقيف والتعزيز الصحي تعزيز برعايتهم ماراثون ومؤتمر كلية العلوم الطبية التطبيقية الدولي الثالث. الجمعية السعودية للبصريات وعلوم الرؤية، الجمعية السعودية للعلاج الطبيعي، الجمعية السعودية لعلوم المختبرات، جمعية هشاشة العظام السعودية، أما الآن تكريم اللجان المشاركة، تكريم فريق التعاملات الإلكترونية الأستاذة أماني بن حميد العنزي، الأستاذة ريا صالح الفوزان، مرفت سعيد ومحمد حسين، الأستاذة سحر السهلي، الأستاذة مها الريس، الأستاذة مرام القحطاني. تكريم فريق العلاقات العامة والإعلام بالجامعة. تكريم الأستاذة شروق العيسى. الأستاذة أروى الدوخي. الأستاذة عبير الحارثي. تكريم مساعد مدير إدارة الصيانة بالمدينة الجامعية الأستاذة بدرية العمري. أما الآن مع تكريم لجان المؤتمر. تكريم لجنة التسجيل والموقع الإلكتروني برئاسة الدكتور عبد الرحمن بن محمد السبيهين. فليتفضل أعضاء اللجنة لأخذ الصورة التذكارية مع راعي الحفل. تكريم اللجنة العلمية برئاسة الدكتورة سارة بنت إبراهيم المشرف. أيضا فليتفضل أعضاء اللجنة. تكريم اللجنة التنظيمية بقيادة الدكتور سلمان بن محمد البيشان. تفضل اللجنة أيضا. تكريم اللجنة التنفيذية برئاسة الدكتورة مضاوي بنت إبراهيم بنت محمد الضويان. فتفضل اللجنة أيضا. أما الآن تكريم لجنة العلاقات العامة والتسويق بالكلية. فليتفضل الفريق. تكريم الأستاذة الغالية بنت عبد الله الغفيلي. وأخيرا تكريم الأستاذ وهبي محمد لجهوده المثمرة في هذا المؤتمر. نشكر راعي حفلنا الكريم على حضوره وتواجده. نلقاكم بعد قليل في استكمال المحاضرات. طلابنا الأعزاء، قبل ما تمشون يا شباب في صورة جماعية. تفضلوا المسرح يا شباب ويا بنات. وننوه مرة أخرى ستستكمل المحاضرات إن شاء الله بعد الحفل. في درون
شباب بنات
الحضور الكريم، شكرا لحضوركم وتفاعلكم. سنبدأ الجلسة الآن. نرجو أخذ مقاعدكم كرما.
بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته جميعا. It's my absolute pleasure to welcome you to the third and last session with what promises, inshallah, to be a fantastic and insightful presentation, بإذن الله, presented by our valued speakers. Our session, inshallah, will shed light on biotechnology, 3D printing, telemedicine, and radiology by a distinguished group of experts who will be, inshallah, so informative to us. Without any further ado, I'd like to welcome our first speaker, Dr. Hana Sbayil. Dr. Sbayil is an associate professor and consultant in physiotherapy at King Saud University. Dr. Sbayil received her master's degree from Queen's University in Canada, followed by a PhD degree from King's College London in the UK, with almost 30 years of experience in academia. Dr. Sbayil played a key role in the development of the physiotherapy profession here in Al-Mamlaka Al-Arabiya Saudiya, and she established the research chair for healthcare innovation at King Saud University. Dr. Sbayil, the floor is yours. تفضلي دكتورة.
السلام عليكم جميعا ومساكم الله بالخير. Thank you for sticking until now. And I can feel the positive vibes in the room after all the nice presentation before the session. And I would like first to thank the organizing committee and the scientific committee for inviting me to talk about this project, which was a collaboration between UK University and King Saud University. And as the title says, it's we've developed an educational resource for allied health professionals to help evaluate digital innovations and digital health applications. And throughout the day yesterday, there has been talks about the importance of data and the importance of digital technologies in promoting health and promoting quality of life, and how can we use these resources to promote and to improve the outcomes of our societies and patients. I will start first of all with disclosure. I have nothing to disclose. And I will start also to just remind ourselves of the Saudi context. What is happening at the moment in regards to digital health and digital innovations? We all know that the Vision 2030 based on three main pillars. And all these three pillars, the vibrant society, the thriving economy, and ambitious nations, they all, one of the enablers is digital technologies and digital innovations. One of the transformation programs that was led by Ministry of Health is the healthcare transformation. And in the healthcare transformation, as you can see, there are three levels of objectives in this strategy. And one of all these objectives, they are supported, and one of the enablers is digital health and innovation. We all know that there has been launch of the model of care, and we need to put this in our minds when we talk about innovations and when we talk about digital health. The new model of care that has been launched a few years back by Ministry of Health is based on the biological, social, and psychological aspects of health. So it is kind of a holistic approach, and we've been talking about holistic approach all day yesterday and today. we need to bear this in mind when we talk about digital innovations and digital health. I will move on to the key areas that we face in order to implement these innovations or to implement this model of care. There are the key areas of facing us, our challenges that are facing us in healthcare. Public health and the change in demographics. This conference is about longevity and about healthy aging. And yesterday we've been talking about all the issues related to this matter and today as well. And these changes require different way of management and different way of thinking, and we need to shift our mindset and paradigm. There are issues related to financial sustainability and technology and innovations. We need to think differently in order to face these challenges, and innovations are one of the important areas. And also there are challenges and we face them every day in delivery and effective delivery and the quality of the services that we are providing, and of course the workforce. And yesterday in the panel discussion, one of the main areas discussed yesterday was about how to develop the skills and the competencies of our workforce in order to be more innovative and to be more educated in regards to digital health and digital innovations. So the main aims of healthcare is to have better health, to provide better care, to have better sustainability financially, and we have a better workforce. And since we are under the umbrella of King Saud University, I think this is an area that we need to look into in order to provide to improve the competencies in the workforce. And for that reason, there was this talk that I'm going to present. It's one of the activities that to promote competencies in regards to digital innovations. And I will present to you the resources that we have developed in this research in order to support this aspect. So if we talk about digital health transformation, we all know that digital health is the main area of focus for in Saudi Arabia. And maybe 2020 during COVID, this appeared very clearly, and the COVID actually accelerated the use of digital health. And as you can see, this is the transformation since 2010. It wasn't just 2020, since 2010, the Ministry of Health has been working on developing or transforming the health sector to be more digital and more accessible. And these are the main strategic objectives. I will not go through them. You can find them in the website, the Ministry of Health website. But as you can see, it's all about personal experience, efficiency, effectiveness, equity, better delivery, better access, and also research. And yesterday we talked about data and how can we use data for better outcomes. And as researchers, we have a big role in this area. Now, the project that I'm going to talk about is a collaboration between King Saud University and Keele University in UK. And the aim of the general aim, or the big aim of this project was to build capacity in achieving clinical transformation from allied health professionals for digital evaluation. All of us, we use digital technologies, we use applications, but for us as allied health professionals, if you want to choose or select or evaluate the the best applications or the best technologies for our to benefit our patients, this is the area that we don't have enough knowledge and enough expertise in. Hence, this project was has been started, and this is funded by the UK Saudi Challenge, which was announced by the British Council 2 years ago, and I was fortunate enough to be part of this fund, and we were able to do this collaboration between King Saud University and Keele University. Keele is in UK and it's in the Midlands, and of course College of Applied Medical Sciences, it's in Riyadh. So these are just to give you an idea of the two collaborators. And this is the research team. The Keele University research team was led by Professor Jonathan Hill, who is also a physiotherapist, and he is his expertise is actually in digital innovations. And the King Saud University team was led by myself with membership of my colleague, Dr. Mayed Dir, she's sitting there, and Dr. Mohammed Bates from College of Medicine. And there is also the industry partner from Denmark, which supported the digital aspect of this project. The project purpose was to build capacity, as I mentioned, and there are two arms of this project. One of them is to conduct research evaluating in the feasibility of a digital app, which is Self-Back, as you can see, and using the screening tool StartBack within the context of Saudi, within the Saudi context. And we did this project in in the College of Medicine. The project is already finalized, and we are now in the process of data analysis. But I will be talking about the other part, which is developing a collaborative set of learning resources to educate the academic and students for digital innovations, to evaluate digital innovations. And this is my focus of the talk today. The problem that we are facing in this regard, that this digital transformation in healthcare is actually is one of the highest strategic objectives of both UK and Saudi. Therefore, the collaboration was very beneficial. The implementation of new technology is occurring very fast and rapid pace. However, the evaluation of these technologies is not keeping up with this fast pace. Therefore, we wanted to see what is going on among the allied health professionals in regards to this area. So the aim of this project was to explore their knowledge, confidence, experience, and what kind of training they've been attending, and it's kind of a needs assessment. We wanted to know their needs in order to develop these resources that will help them evaluate the digital innovations. So we developed a survey, and the survey based on, we did a scoping review of different documents and different resources that are available there, and we did a focus groups with stakeholders, and then the final survey was distributed among UK allied health professionals and Saudi allied health professionals. And maybe some of you received the invitation to participate in this survey. So I would like to take this opportunity to thank you if you are one of them. The final survey has 4 sections. Section about demographics, digital experience, digital health interventions, and in clinical practice, and evaluating and their experience in evaluating digital health interventions. We got the ethics from Kiel University. We used a mixed method design, so we had quantitative and qualitative assessment or evaluation. And then the recruitment, we use different methods. One of them is snowballing sampling, advertisement in social media, and also we distributed the survey through the allied health professionals societies. Most of the analysis is descriptive because this is a needs assessment. We wanted to explore their needs in order to develop these resources. These are the participants, 83 participants. Most of them were from UK. The age group, as you can see, they are around 40 years of age. These are the different professions that contributed or participated in the survey. Most of them are from rehabilitation disciplines. And these are the different educational levels. Most of them are within the undergraduate. They have either BSc or BA. Most of them are clinicians. Their working hours, most of them are full-time, and they have an average of 15 years of experience in their work. To evaluate their use and evaluation of digital interventions, there were two main questions. One question is, are you aware of any digital health interventions being used in your AHP profession? And the majorities, half of them, they said yes. Or more than half, they said yes, they are aware. But awareness doesn't mean that they know how to use or that they know how to evaluate. And the second question was, are you aware of how any of these digital health interventions were evaluated? And the majority, they said no, no or not applicable. And the not applicable is the people who said no already. So there are areas of unclarity among the allied health professionals. And the key components that were recommended or suggested by the group were, as you can see on your right-hand side, evaluation. That these are the areas that were not clear to the participants. Evaluation in the context relevant to the patient population, understanding of how the interventions fit within local practice, and so on. The resources, then we asked them about resources for the evaluation of digital health interventions. So we gave them a number of resources and we wanted to see if they are aware of these resources, are they using them? As you can see, these are different resources and most of them are actually international or UK based. And there was one question to the Saudi Arabian government national e-health strategy, if they were aware of it or not. And unfortunately, the majority, they mentioned no or not fully aware of these resources. We asked them also to provide if they have any other resources that they were aware of, and they provided number of resources. One of them is the Saudi Arabian Ministry of Health Transformation Plan. So this was suggested by some of the participants. Then we asked them about the training needs. What do they need in order for them to be able to evaluate the digital innovations? And 11% reported that they had received training covering these areas: virtual clinics, IT system design, etc. So it's very small number from the participants who actually had training in these areas. And then we asked them to rank the importance, which areas the most important for them. And as you can see, the top 5: user engagement, data security, intervention design, and accessibility, etc., etc. So all these are ranked by the participants, the 10 most important areas that they wanted us to tackle in our education resources. So from all this data, we managed to put together a program, the online program to help the allied health professionals to be more of able to evaluate the digital health learning and the digital health innovations. And these learning are all online, and they will be soon available for free in the NHS, which is the National Health services in UK. It will be available for everybody internationally. So the resources based on the information gathered from the group include introduction, some aspects related to the data, what is data and how can we tackle data, digital service delivery and improvement and innovation. Each of these modules, so 4 modules, each of these modules consists of suite of bytes, small bytes. They finish one section and then they move on to the next section and then the next section, and then at the end they will have a certificate. So each one is about 10 to 15 minutes to complete. So it's not very heavy. So they can use these resources and they can continue the resources on their time. It's not very long. So what's next? So the resources are available, will be available soon, and I can share the link through the college email for everybody to use these resources. And now that we have the resources and we are about to finalize the other project or other research related to this project, what's next? What's next is dissemination. So we wanted to have all this available for everybody. And this will be, as I mentioned, distributed to everyone. And what's next in relation to the other project? It is in its final stages, and it's a feasibility study. So hopefully we will be able to continue this trial as a clinical trial on a larger scale for multiple centers. And also what's next is to continue collaboration with the team from Keele University. And just recently we have applied for funding for the RDI, and then we are hoping that we get this funding, and then hopefully we continue with this theme of digital innovation across allied health professionals. So at the end, I will finish my talk with a glimpse of our visit to Keele University with my colleague, May. And I would like to thank Dr. May Rashid, our Dean, for her continuous support for this project and another projects. And of course, I would like to thank Dr. Mishal Al-Dehan, our Head of Department, for his tremendous support throughout this project. And you know how much we've faced until we got this alhamdulillah finalized. And I would like to thank all my colleagues in CAMS who participated or supported in any way, our colleagues in College of Medicine, of course, our member collaborators from Keele University. Thank you so much, and that's it from me. Thank you.
Thank you so much, Dr. Hana. Our next speaker is Engineer Muad Abu Aisha. With over 10 years of specialization in 3D printing, Muhandis Muad leads cross-functional research and development teams at NEOM. Muad holds certifications from MIT and the American Society of Mechanical Engineers, and his achievements in the field have been recognized with awards from prestigious institutes such as Intel and MIT, particularly for innovation and contribution to medical technology. So let's welcome Muad to take the floor. تفضل مهندس.
يا هلا والله وسهلا، حياكم الله. كيف حالكم؟ طيبين ان شاء الله. عادة أنا أعتاد في محاضراتي يكون سمبل، بسيط، سريع، شوية انجلش شوية عربي، بس بكون بسيط جدا. وأتمنى المقاطعة. I love cutting. So please cut me whenever you have time. أنا coming يعني من نيوم. اليوم I arrived. After I want to just tell you something that new we have done.
I'll cut you just for a second. Let's keep the questions to the panel discussion, inshallah. So we'll have you 10-minute discussion.
بس إذا واحد متحمس وعنده سؤال مرة أسمح له عادي.
Well, the floor is yours.
طيب إن شاء الله. Okay. Should I speak in English? Should I switch in English?
اللي تبغاه.
خلاص زين الله يعافيك. ففي كذا exclusive news أنا I would like actually to share. يعني تخيلوا أنتم اللي في القاعة الوحيدين اللي بتعرفون معلومة جديدة. We just finished completing a 3D printed fully unit material سعودية بمدة 16 ساعة. تخيلوا البارح هذه، وفولي سولار بانل، يعني fully powered by solar panel، ما لها كهرب، ما في لها شيء، تطبع 16 ساعة ويدليفر وتنتهي. تقول ايش دخلك الحين في البايوميديكال وهذا؟ بس انه 3D printing is a wonder. It's a crazy technology. تعرفت عليها تقريبا في عام 2009 I got blown away. إلى اليوم وأنا أقرأ وأبحث على كثر ريسيرش، على كثر المشاريع اللي اشتغلتها. اليوم أكلم دكتور عبد العزيز، قبل أمس كملنا يمكن 300 عملية استخدموا فيها 3D printing في السعودية، which is something great. إن شاء الله عقبال ما we complete يمكن all the regulation اللي موجودة تخليها متاحة. ولكن this technology we just peeled, I would say, the first layer of the craziness that can bring to the world of medicine صراحة. Because I've seen cases. I'm going to share with you cases today. الفكرة الأساسية إنه نبغى نعرف is this a joke? Is it just one of the fancy technologies that people wear? VR glasses, augmented reality, something يعني يستخدم fancy, good to be in the news. ولا it's really a technology that actually contribute in the longevity of life, actually provide something new. There's a cases of patient actually يعني benefited from this. أنا في العادة صراحة في يعني محاضرات أحاول بسريع أعطيكم كذا نبذة سريعة. What's 3D printing? What's the technology there? يمكن you've seen the presentation multiple times. I'm sure ماجد هنا شاف البرزنتيشن ثلاث مرات. بس it's good always to come and to see the level of complexity شوية في 3D printing, and then we'll dive into the utilization of 3D printing in medical field, which will يعني إن شاء الله result in longevity of life. لكل شيء بداية. ما تصورون لما أقول لكم أن طباعة الأبعاد الباتنت الأولى كانت في 1984. سلامات 30 سنة، أكثر من 30 سنة صحيح؟ That's crazy. ليش ما شفناها يمكن لآخر 10 سنوات؟ طبعا مسألة الباتنت والريستريكشن على الباتنت، طلع براءة اختراع، بعدين تكون محكورة من شركة واحدة، بعدين تطلع. بعد ما انتهت 20 سنة انفجرت الشركات في تصنيع الطابعات لنوعين رئيسية: الطابعة الديسكتوب اللي تشوفونها على الطاولة، والطابعات البروفيشنال اللي هي تكون عادة يعني لها constructed environment، لها its own space. يعني طبعا مرت بأكثر من عالم اللي فوق تشوفونهم، يمكن راح أمر عليهم بالسريع. It's multiple publications that you do today, you contribute with today. في الأخير هي راح تتحول إلى patent إن شاء الله along the way. والpatent need to serve a commercial application. هذا الطريق الصحيح لبراءة الاختراع يمكن I would say البيبرز. أنا يا إما تروح تعالج مريض أو يا إما تطلع لي فلوس، واحدة من الثنتين، ما تجلس في الدرج. يعني this is the most important thing. بعدين مرة طبعا على multiple inventors. طباعة الأبعاد يعني بدأت بداية بسيطة جدا، اللي في الجراج واللي في اللاب. زي ما نشوف كثير من research today started from small labs، بس الحين نتكلم على multi-billion companies, 3D system companies, Solaris company، اثنين massive company they contribute في الميليتري، في الميديسن، في السبيس and غيرها. طباعة الأبعاد هو اسم تجاري يستخدم. الاسم الأساسي اللي هو التصنيع بالإضافة. كثير منكم يمكن يبغى يبحث في الريسيرش، يبغى يتعمق بشكل أكبر. في عالم الريسيرش نستخدم AM additive manufacturing. This is the right terminology to search with. في مظلة كبيرة. يمكن أنا جماعتي يمكن هنا يمكن I would say the most used technologies. You've probably been exposed to two of them. اول واحده الفت فوتو بوليمرايزيشن، العاده ليكويد بلاستيك راح نمر عليه. ثاني الماتيريال اكستروجن، ماتيريال جيتنج، بعدين بايندر جيتنج، بعدين باودر. شو الفرق بينهم؟ كل تقنيه يعني التقنيه الثانيه، واحده تقول لك انا اطبع فقط بسائل بلاستيك، الثانيه تقول لا خلينا نضيف لون زايد، الثالثه تقول اوه عندي variety of materials we can use، الرابعه تقول you know what I will give you all color printing and this is the differences between each technology that we do have هنا. ناخذها واحده واحده سريعه، اطب فيكم كذا طبه انجينيرنج بعدين نطلع ان شاء الله للكول ثينجز والابلكيشن. ذات فوتو بوليمرايزيشن التقنيه بسيطه جدا، هو عباره عن ليزر على حوض من البلاستيك. انتم كلكم رحتوا يمكن سويتوا حشوه في يعني في اي عياده اسنان، شوف يجيب لك الليزر الازرق في السالفه. الفكره انه تكيورت اتس يو في لايت، سو يحطون المعجون وبعدين اتس ريزن يوجوالي لايك وات وي هاف هنا، فمجرد ما يجي عليه اليو في لايت will solidify the material to make it يعني solid. بعدين تخيل لاير ثانيه ثالثه رابعه خامسه سادسه يطلع لك 3 دي printed موديل. طبعا لها اقسام كثيره يمكن ما مريت عليها، يعني واحده الليزر يتحرك، الثانيه لايت تك تك يصير كنا بروجكشن لايتس. الفكره انه هاو تو solidify ذا ليكويد اللي موجود بحيث انك تطلع لك الشكل الكومبلكس هذا. اف دي ام اكثر تقنيه معروفه مشهوره، كثير منكم يعني يمكن شافها، روله ببلاستيك تروح وتدوب ببلاستيك. هي ليش مشهوره؟ لانه رخيصه جدا، الاكسسبيليتي كانت عليها عاليه. مشهوره باسمين اف دي ام واف اف اف، والبراءه اختراع على اف اف اف. هذه تقريبا طريقه الطباعه. لو نمر على التقنيه اللي بعدها، وهذه كانت جنب كبيره من الاس ال اي الاولى والاف دي ام، اللي هي الماتيريال جيتنج. material jetting now we're talking about multiple materials. انت الحين تبي تطبع simulated او تسي simulated skull مثلا، فيها لسان، في مصل، في ماندبل، عندي مجزله، عندي اسنان، كل التفاصيل هذه الصغيره ابغى اطبعها ب different materials different colors different حتى opacity، يعني يصير واحده منها مثلا transparent الثانيه تصير قويه. فالماتيريال جيتنج اقرب شيء للطابعات الحاليه الحين اللي نشوفها اتش بي، فعندك زي الكونتينر في multiple material ويطبعها في نفس الوقت وبعدين كيورت، فيصير عندك موديل كامل موجود في مالتيبل ماتيريالز. الماتيريال تكون سوليد مطاطيه وتكون مثلا شفافه وغيرها. طبعا هذه كانت قفزه من التقنيات اللي بعدها. بعدين عندنا البايندر جيتنج. البايندر جيتنج استخدمها بشكل كبير في المجال الطبي. ليه؟ لانه فولي كالرت. اخيرا انت تبغى تشوف شيء تبي تعرضه للمريض قبل العمليه، مثلا تريسكت تومر، فتبغى يكون عندك مثلا العظم موجود في التومر وتبغى تشوف من الاحمر من الاخضر، وتشوف مثلا المارجن ارياز اللي يمر عليك نيرف فيها، يمر عليك بلد فصل وغيرها من التفاصيل. فذس از ذا بايندر جيتنج برينتنج. فكرتها انها عباره عن لاير من الباودر زي الجبس ينزل، وبعدين عندك بايندنج ايجنت. البايندنج هو عباره عن ليكويد عاد جلو. تخيل انت تحط جلو كذا، بتحط بودر مره ثانيه، تحط جلو ثالث ورابع وخامس سادس الين تسوي لك an additive manufactured model. بعدين القفزه اللي بعدها، القفزه الثانيه كانت اللي قبلها اللي هو الالوان او المالتي ماتيريال. القفزه اللي بعدها الكبيره كانت اللي هو الميتال. الميتال to be printed is one of the most complex things، ولكنها يعني كانت من احد اجمل القفزات خصوصا في العالم المجال الطبي. كذا احنا when we talk about 3D printing مش دخله في الميديكال فيلد، very important to know انه احنا كل واحد جالس، انا عنك افرق صح؟ كل ستراكشر صغير يفرق، خفه العظم يفرق، الستراكشر حق العظم يفرق، مكانه، شكله، كل التفاصيل هذه الصغيره. 3D printing فكرتها الكستمايزيشن، ان يكون عندك شيء مشخصن ويعني مصنوع بطريقه it doesn't work except with one patient and one patient only. الشيء الثاني انه تكون مفرغ من الداخل. تخيل عندك يعني انت الحين لو تشوفون تاخذون كروس سكشن من اي عظم بتشوفون في التجويفات والتفريغات هذه الموجوده. ما في تقنيات ثانيه كثيره مثلا من اللي يسمونه ميلينج ولا السي ان سي تكنولوجيز ولا غيرها. you could mill a metal صح، you could implant it، بس ما راح يكون بالوزن اللي انت تبغاه، عاده يكون مليان من داخل مو مفرغ. نجي عادة لمسألة التقسيمات. الحين احنا عندنا اوردر، عندنا يعني طلب، كيف نقدر نقسمها؟ اي ماتيريال يعني من الماتيريالز هذه تودينا لاي تقنيه من التقنيات. يعني اذا كان عندنا بوليمرز هذول التقنيات اللي نستخدمها، اذا كانت عندنا ميتالز هذول التقنيات، اذا كانت عندنا ساند هذول التقنيات. وهنا بالنسبه للفانكشن هذه تساعدنا فقط في اختيار واتس بيست ميثودولوجي بس تكنيكس to utilize من 3D printing. فتشوفون التقسيم مثلا، والله انا ابغى شيء يكون high strength وابغى مثلا السترينث حقه يكون ما بين 30 to 85، نستخدم SLS selective laser sintering مثلا. ابغى فود سيف، ابغى يتحمل حراره اقوى، ابغى biodegradable. فهذا التشجير اللي هنا يعلمنا تقريبا تفاصيل هذه بشكل افضل. هنا الفيجوال appearance، if I'm doing something مش functional اكثر نبغى شكل. فاللي يعرف ال 3D printing يعرفون انه لما نطبع always our biggest يعني thing that we hate اللي هو ال support materials. ما تقدر تطبع الهواء، لازم يكون في support موجود. When you remove the support usually it leaves residuals that يعني nobody likes. فهنا نختار ايش التقنيات الافضل. Let me jump now to the application. راح اتكلم اليوم يمكن على ايش هي استخدامات طباعة الابعاد في المجال الطبي. عادة احنا نمر في المراحل هذه على اساس نبدا اي حالة. طبعا this is a general لكن يعتمد على الحالات. اذا كان عندنا حالة مثلا نحتاج نصنع لها امبلانت، اذا كان عندنا حالة نحتاج نصنع لها فقط سيرجيكال جايد محدد جراحي، اذا كان عندنا حالة نصنع لها مثلا فقط بري سيرجيكال مودلز. كل حالة وكل سبب له يعني خطة مختلفة، لكن هذه خطة عامة. هنا نتكلم مثلا عن الامبلانتس. اول شيء ناخذ اللي هو الصور المقطعيه، يعني سي تي سكان سواء كانت ام ار ايز على حسب الحاله، لكن هنا سي تي سكان هي اللي نحتاجها لان راح نطبع عظم. وبعدين تدخل في سوفت وير ثاني، السوفت وير نسوي فيه السيجمنتيشن، نطلع العظم فقط من كل شيء اخر. بعدين عندنا سوفت وير ثالث، الان نحدد المنطقه اللي راح يكون فيها الجراحه او ريسكشن. يمكن يكون في تومر، يمكن يكون في congenital shape that we need to resect and remove. هذا السوفت وير الثالث. السوفت وير الرابع نروح للمنطقه الحين نصنع اللي يسميهم surgical guide which I'm gonna pass through. surgical guide هي عباره عن مسطره بس خاصه فقط في المريض هذا، تستخدمه تقص فقط المريض هذا، مشخصنه فقط للحاله اللي انت عندك. وبعدين عندك اللي هو مرحله صناعه الامبلانت في الاخير. طبعا منكم تقولوا لي وش المواد اللي نقدر نطبعها وتكون يعني ايزي امبلانتبل ما يحاربها الجسم. one of the best materials it's a roserized of plastic انا اسميه اللي هو البيك او البيك، بس البيك بولي ايثر كيتون. يجي على lot of grades، لكن انا اتكلم على الامبلانتبل جريد. it's very good. مشكلته مع 3D printing if we printed it that way الى الان الريسيرش قائم didn't get certified yet لانه عندك لاير صح، واللاير فيها الجروفز هذه الصغيره وممكن تكون يعني habitat for some يعني unwanted bacteria during يعني من الكلينينج للستريلايزيشن للدخول في عمليات. خلينا نشوف احد الحالات اللي موجوده. انا باخذ من هنا يمكن حاله واحده ونشوف خلينا نشوف الحاله هذيك مثلا السكال الرماديه اللي موجوده. السيرجري each minute means something. each minute the patient under anesthesia, each minute the patient losing blood, each minute it's something. losing حتى money، خلينا نتكلم بعد ماديين نكون. ف with 3D printing احنا we try as much as we can to do a lot of planning بعدين execution. ما نبغى الطبيب يفكر كثير during the surgery، نبغى يفكر قبل السيرجري، نبغى يسوي كل البلان before. عندنا احد اهم الاشياء اللي هو bending of the plates. تشوفون التيتانيوم بليتس اللي موجوده هاي تجيك في كيت معينه. داخل العمليات العاده الجراح في الوقت الحالي يدخل قص مثلا التومر، يبغى يحط البندنج بليت، يجلس ما يقارب من نص الى 45 دقيقه فقط بند بليت يا جماعه during the surgery. ف 3D printing بكل بساطه تاخذ سي تي سكانز الامرايز، تطبع المجسم برا، يجلس على راحته يتكي يشرب شاهي and bends the plate على 3D printable model which is identical to the patient's skull. فيصير يدخل عمليه الحين ويكت كم؟ ويكت 45 دقيقه. خلينا بجيب لكم الكتسه الثانيه اللي راح نسويها. حالات كثيره موجوده عندنا، مثلا هذه حاله كانت في قياده الدكتور الجباب عبد السلام الجباب من المكفاه الطبيه، كانت very complex. We made multiple skulls for the surgeon to train on. الحين اي جراح موجود اذا يبغى يسوي عمليه، وش الشيء اللي يسويه قبل العمليه توقعون؟ يجتمعون اللجنه الطبيه، يشوفون السي تي سكانز والام ار ايز، يحاولون يخططونها، يشوفون the most recent articles what's the best approach، بس ما عندهم a physical element انه يقدر يجرب عليها ترين. كل التريننج موديل والسيميليشن فيكست. تروحون سيميليشن سنتر it's the same one, it's identical، بس ما عندهم identical مجسم للحاله اللي راح يطلع عليها بكره. ف this is where 3D printing comes in to have I would say the memory muscle of the surgeon to be practiced prior to the surgery. الحالات الثانية اللي هو الأجهزة التعليمية المساعدة لطلاب الزمالة. طبعا هذا كان قبل الله أعلم كم سنة، الحين أنا ما شاء الله طفل كبير بس هذه كانت قبل 9 سنوات في كندا. بس كانت هنا الحالة هذه كان في كندا عندهم الجهاز اللي موجود اللي ستيريوتاكتيك سيستم، هو عبارة عن جهاز يستخدمونه النيوروسيرجنز إذا كان عند المريض حالة يسمونها هيدروسيفالس، يكون في تجمع للدم في الحجر الموجودة في الدماغ، فلازم يدخلون زي الفي بي شنت تدخل في منطقة معينة وبعدين تسحب لك الدم والقش اوتسايد عشان تساعد الدماغ عشان يتنفس قليلا. فالفكرة أن كان عندهم هذا الموديل تقريبا 132,000 دولار، غالي جدا. ف 3D printing what you do أنت تقدر تاخذ المجسم نفسه، تقدر تسوي له سكانينج، تقدر reverse engineer it and then you print it and then you give it to them 500 ريال to make the surgeon train on it. وأشياء كثيرة ثانية زي الحالات اللي يكون فيها congenital diseases. اشتغلت مع أكثر من حالة مع دكتور هاني نجم، ما أدري تعرفونه ولا لا. he's the head of cardiovascular pediatric في أوهايو، ما شاء الله فخر لنا يعني دكتور هاني نجم. ويشتغل، شوفوا ادخلوا على حسابه الآن راح تشوفون أهم شيء عنده إيش؟ 3D printed hearts. هو الأول عالمياً. إيش اللي ساعده؟ 3D printed hearts. الحين خلينا we link it to عنوان المحاضرة longevity of life. If we don't have a 3D printing, he wouldn't plan well. بعدين بعد فضل الله he wouldn't have give يعني I would say life for these children to grow. And الحين أنا شغال معاه على حالة it's very beautiful. He had a patent. I'm working on manufacturing the expandable valve. عنده مشكلة إنه البيدياتريك الأجنة لما تولد وكان عندها ثقب في القلب أو عندها مشكلة في نفس الصمام يغيروا له القلب، لكن يغيروا له إياه بعد فترة لازم نسوي عملية ثانية عشان الطفل يكبر. لكن we're doing now 3D printed mechanical heart الفالف أقصد صمام، بحيث إن كل ما يكبر المريض يتوسع معه حتى الليفس تكبر معه. So this is the beauty of 3D printing. They can print in small scale tailored to each patient. أطراف الصناعية والأشياء الأساسية اللي تكون يعني كثير من الناس اللي شوفوا آخر تغريدة البارح كانت تتكلم عن هذا الموضوع بالذات. 3D printing فيه له دقة عالية جدا جدا جدا، يوصل إلى تاخذ شعرة، روح قسم الشعرة تقريبا 10 أقسام، بعد ياخذ لك واحد من الأقسام ال10 للشعرة، يطبع بهذه الدقة. تكلمنا عن البث polymerization، يوصل ترى للنانو بارتيكل ليفل which we have printer I collaborate with الكاوست جامعة مكة عبد الله العلوم والتقنية. We could do a lot with the 3D printing to small devices. بس ليش أتكلم عن الدقة؟ لأنه we could print a lot. This is not printable by the way. هذا نطبع القالب to be injected with silicon and the silicon to be utilized يعني later on. الزراعة المعدنية، وتكلمنا عن الزراعة المعدنية وتفصيلها يمكن قبل. الزراعة المعدنية عالم مختلف، كان صعب جدا وكان معقد بشكل كبير جدا لأنه ثقيلة يا جماعة، شكلها ما راح يركب في المكان اللي نبغاه، وعادة تكون يعني some areas you need metal, you need that strength, you need particular mechanical property. والله ما راح تشتغل معك. فتخيل انك تطوع العظم للتفاصيل الصغيرة هذه، لا وتطوع ايش؟ تطوعه ل specific patient. فأنت you're manufacturing to a specific patient. This is crazy ترى. This is amazing. أساس كذا أقول أنا ما قاعد أمدح الذي يحب 3D printing، قاعد يعني أرفعها لكم. لكن this is amazing because I've seen my patients. أنت patient يطلع لك قبل العملية نص وجهه مش موجود، بعد العملية تشوفه خلاص الحمد لله structure it's fully constructed. This is amazing. That's why استخدام التقنية خصوصا هذه في الميديكال فيلد it's not a luxury, it's a critical and important. السيرجيكال جايد، يوم نتكلم لكم عن السيرجيكال جايد، السيرجن لما يدخل غرفة العمليات زي ما قلنا نرجع الحين وي كاتنج صح، وي كاتنج ذا تايم في العمليات. السيرجن شطارته انه هي ديبج لما في نص العمليه يعرف وين اماكن النرفس، يعرف وين اماكن البلد فيسلز، يعرف الكالكوليتد ريسك، ودائما يقدم للبيشنت قبل العمليه ايش؟ كونسنت فورم. عندك انتبه ترى we have the risk to lose this nerve, we have the risk to do this mistake. with 3D printing انت تدخل الجراح على ليجو وولد، خلاص في بلاج اند بلاي. احنا الحاله هذه، خلينا نتكلم عن الحاله اللي تحت مثلا هذه. اتس اورثوجونيتك سيرجري، عاده هي عباره عن تقديم الفك للي عندهم مثلا متقدم الفك كلاس 1 وكلاس 2 وكلاس 3. فالفكره انه كيف يو gonna موف الفك and you're gonna tilt it millimeter tilting specific degrees specific forward movement. الان حاليا الجراحين لما يسوون كيف تتوقعون they measure exact millimeter accuracy? It's very hard. لذلك يعني الديجيتال وورلد في الديجيتال سيرجيكال بلاننج will help a lot in this aspect. هنا الجراح قبل يعني يخاف لما يقطع، يقول يا رب ان شاء الله I don't knock a nerve ولا blood vessel، خصوصا المنطقه هذه. صراحه لو اي واحد منكم يمسك صبعينه ويضرب هنا شوي شوي يحس بكهرباء بسيط. This is a very يعني very sensitive area، المنطقه هذه اللي فوق المجزله شوي وتحت الزيجوما. فالفكره انه في العمليات لا، عندك 3D printed tailored مقيوسه بالضبط، يعني هو يشيلها ويضغطها هنا تركب بالضبط في مكانها with millimeter accuracy على نفس تعرجات العظم. and then he start cutting وهو متكي، لا cutting وهو متكي، يعني هو يضحك. I trust the plan, I did the surgical guide and I cut. So assuming اني انا طبعا I don't mess up ولا يعني surgical planning team الانجينيرز هذول المجانين اللي داخلين في المجال الطبي ان شاء الله they don't يعني mess up on this. بس طبعا during all the planning phase هم معاك يعني في كل الفتره هذه. فانتم الحين عرفتوا معاي كم الوقت اللي ممكن يختصر للطبيب في فتره الكت، عرفتوا كم الاكيوريسي، الانجليشن، التلتنج، الفوروردنج، كل التفاصيل هذه could be prior calculated to surgery. احنا يمكن في الانجينيرنج يمكن عندنا البلاننج كذا هذا كبره، والاكسكيوشن يمكن يكون كذا. we plan when we execute well. في الميديكال فيلد this is what I صراحه aspired. يعني انا قلت ليش ما we bring this planning aspect, the hardcore planning aspect to surgery، يصير ما تعتمد subjectivity، لا it's a probability. عندك ارقام، عندك calculated risk، عندك digital plan, so you would anticipate the mistakes and the risk for the patients. آخر شيء اللي هو طباعة ثلاثية أبعاد الحيوية. This is an amazing يعني topic. أي أحد مهتم في طباعة الأبعاد، شفت اللي قلته أنا ورا، مع أن this is actually really cool. This is what the future is. احنا نتكلم عن أخذ الخلايا الجذعية وبعدين تخليها أنت في restricted environment to grow it and then to create an organ with it. أنا معليش قاعد أبسطها بشكل عالي، لكن it's much complex than this. دكتور أنتوني عطلة he's one of the pioneers صراحة. I had the pleasure to work with him تقريبا بشهرين. كل شغله يشتغل على ال 3D printing of kidneys. في عام 2011 there is a fully printed bladder الله يكرمكم been implanted the patient، ما شاء الله ما زال الحمد لله بصحة وعافية. نتكلم عن organ fully printed outside and successful. So عندنا في عام 2000 في الأزمة وقت كورونا في عام 2020 كان في printing للغدة الدرقية. الحين بس بصدمكم كذا بشوية سقوي. البرينتينج كان وين تتوقعون؟ كان في مكان غريب شوية. البرينتينج كان في في السبيس. ايش السالفة؟ قلنا عاد مشينا لك كثير. ايش دخل السبيس؟ ليش they print in space؟ السبيس في زيرو جرافيتي، ولما احنا اصلا نحاول نطبع with bio printing تخيلوا ان الويت حق التقطير، طبعا تقنية طباعة الابعاد الحيوية هو عبارة عن تقطير. الويت حق القطرة على القطرة الثانية اللي موجودة اللي هي collective of stem cells وغيرها they will smooch out، يفعصون بعض باختصار. فما نقدر نخليهم in environment that fixed same level of pushing. طبعا تقولوا طيب كيف يطيحون فوق بعض بالضبط إذا كانت zero gravity؟ هو عبارة تخيلوا معي كذا كورة، والكورة موزع عليها مغناطيس، وأول ما تنزل القطرة الحين زيرو، المغناطيس it's magnetization، فأنت بالمغناطيس تسحبها يمين يسار فوق تحت. So it's a magnet 3D printing as well on the space. نجحوا في طباعة 4 ملي من الغدة الدرقية، وكانت this is one of the best يعني amazing. أنا أسوي ريسيرش الحين، ريسيرش حقي في السبانخ. I'm trying to print spinach على أساس ناخذ العروق حقت السبانخ وتكون تستخدم في simulation أو تبي implanted على الارتريز اللي على الهارت من برا. it's amazing technology لسه في بداياتها، لكن أنصح الناس تطلع عليها بشكل أفضل. وتشوف we're not talking about science fiction زي ما قلت لكم we have done يعني تقريبا عمليات كثيرة اللي وريتكم إياها كلها الصور اللي قبل عمليات موجودة في السعودية وخارج السعودية. So I'm not talking about something outside the world that you cannot search. أنا من اليوم أبغاكم أنتم تروحون تشوفون أوكي السالفة نقدر نسوي هذا الشيء، كيف نقدر نقرب للمستقبل أقرب، لأنه هو بين يديكم. أنتم تحددون whether you bring it closer or you bring it further على حسب الريسيرش واهتمامكم. وشكرا جزيلا لكم، طولت جدا آسف. الله يعافيك. ناخذ أسئلة ولا في البانل؟ طيب إن شاء الله. شكرا جزيلا.
شكرا مهندس. Our next speaker is Dr. Abdulaziz Saifan. Dr. Abdulaziz is an assistant professor at the Biomedical Technology Department at King Saud University and the head of Biological and Environmental Sensing Research Unit at King Abdullah Institute for Nanotechnology. Dr. Abdulaziz obtained his Bachelor's in Engineering, MSc and PhD degrees from the Electrical and Electronic Engineering Department at Swansea University in the UK. Currently, Dr. Abdulaziz and his team are working on the development of biosensors for the direct detection of widely spread diseases and pathogens in the kingdom, while focusing on low-cost and mass production fabrication methods for the development of biosensors. Dr. Abdulaziz, welcome, and the floor is yours.
شكرا دكتور عصام. بسم الله الرحمن الرحيم. First of all, let me take this opportunity to thank College of Applied Medical Science for arranging and organizing this conference. I will take you through a story here in case you about developing nanobiosensors for the direct detection of different biomarkers.
So, Dr. to get the mic.
Okay, so we will talk about nanobiosensors and their contributions to longevity and enhancing life expectancy. First of all, let's describe a basic biosensor. What is a basic biosensor? A biosensor size can span from nanoscale size up to macroscale size. Okay, so basically it's anything that can detect any receptor biomarker interactions and can translate it to any sort of signal. This signal can be electrical, mechanical, optical, or colorimetric. Okay then, so why do we need nanomaterials for biosensors? Nanomaterials can be nanoparticles, nanowires, thin films. Basically, incorporating nanomaterials to your system can enhance a lot of properties, mainly through surface area to volume ratio. When you have nanowires or nanomaterials on your surface, you can enhance the surface area, which means you will have more biomolecules on the surface. So this means the limit of detection, sensitivity, limit of quantification of your biosensor will be greatly enhanced. Okay, so why do we need biosensors? Basically, we need biosensors so that we allow patients to do on-site detection of what they are feeling. So instead of sending samples to central labs, they can basically do these diagnostics at home, okay? So basically we have spread of chronic diseases, we have aging and infectious diseases, which means we have to provide technology that is available for everyone and hopefully enhance the life expectancy. If you look at the pie chart on the right-hand side, this is the market of IVDs or in vitro diagnostics, or in other words, biosensors available at the market. It's dominated by blood glucose sensors. You will be surprised that there is a lot of research still ongoing on glucose sensors because the demand is still going up, okay? Then there is cholesterol, pregnancy test, and so on. So the currently available diagnostics in the market or in hospitals, we have PCR, ELISA, and lateral flow technology. These are the ones in pharmacies which you can buy, and then you can do a quick test, okay? Anyways, these diagnostics suffer from high cost. They are expensive. They require highly trained lab technicians, and they are time consuming. So we need to come up with new technologies okay, that can allow mass screening of diseases or biomarkers, okay? And also anyone can buy them. So basically, we want to allow a wide range of patients to have access to such technology. Okay, so during the pandemic, 2020 or 2019, we united here at KSU with different faculties interested in biosensing, some from electrochemical biosensing background, some from mechanical background, and some from optical background, okay? And we started with that targeting COVID-19. And then since 2020, we have detected more than 10 biomarkers. On the right-hand side, you can see some examples of these biosensors. As you can see, they are very small, okay? They can be 2.2 centimeters by 1 centimeter down to micro scale. And these sensors can be incorporated with nanomaterials as well. Let me take you through some examples, okay? This example is an electrochemical biosensor. It's a 2 centimeters by 1 centimeter biosensor used for the detection of human cytomegalovirus. What is human cytomegalovirus? This virus usually infects newborn babies, and usually it's asymptomatic. So these babies, if they are not detected at early stage, they can grow with some issues, okay? So if we are able to develop new techniques that allow early detection, then we can allow early medical intervention, and we can enhance the life expectancy of these newborn babies, okay? Another example, we have this biosensor for the detection of LDL cholesterol incorporated with nanowires, as you can see on the top right-hand side. This is selective, okay, low cost, and so on. Something to bear in mind that all of these sensors share the same functionalization method, okay? The only difference is the transduction method. So this sensor provides electrochemical signal. Other sensors I will show, they can show mechanical signals and optical signals, okay? So what's next? Regarding these electrochemical sensors, we are planning to do multiplex detection of different biomarkers, okay? So if you look at the left-hand side, you can functionalize the surface of this sensor with different bioreceptors, okay? And this device is incorporated with microneedles. It's like the patch you can buy from the pharmacy, okay? So it sucks blood like mosquitoes through capillary forces, and then this sensor is able to detect the level of these biomarkers. Also, we have developed sensors for detection of heavy metal ions in water. These heavy metal ions can have severe health problems, okay? So basically, we play around with the functionalization, and we make this sensor selective to specific heavy metal ions. For example, in this case, we have a mercury selective biosensor, okay? Since we all know the downsides of mercury intake. Another example, we have lead sensor for detection of lead in tap water. And on the right-hand side, we have received some questions asking about the selectivity and specificity of such sensors. So we have performed some chemical characterization to ensure that we are actually detecting this specific biomolecule. Okay, so what is special about all of this research? So all of these sensors are paper-based, they are flexible, which means they can be worn, okay? So how do we fabricate them? We fabricate them through roll-to-roll flexographic printing, okay? This flexographic printer is used ages ago in newspapers and magazines printing, and also food packaging. So can you imagine using this printer to fabricate biosensors? So you can fabricate millions of sensors in a few hours, instead of fabricating thousands of sensors overnight with an expensive method. Okay, so with this printer, you can only develop an ink. Okay, this ink will consist of your biomarker, bioreceptor, which is selective towards a specific biomarker, and then you are ready to go. So the cost of such sensors produced by the flexographic printer is much cheaper than the traditional fabrication techniques. Let me take you through some applications of this printer in the medical healthcare sector, okay? So this printer was used in the past to print sensors, as I have showed you. It was used to print colorimetric sensors. It's also used to print biofilms, ELISAs. So you can produce a lot of medical technologies at high volume scale with a low cost and with a speed which is much faster than the conventional techniques. Also, on the bottom left side, this is an oral dispersible film. This is basically a drug, okay? Can be produced also by the printer. So with fabricating these sensors with such technique at this high volume, we make this medical technology accessible to a wide range of people or patients, okay? So a lot of people, hopefully, when this comes to the market, will have access to healthcare products, and hopefully we enhance the life expectancy. Okay, let's move to another technology we have in our labs. This is a microchannel on top of a cantilever-based sensor. So this is based on microelectromechanical systems. If you look at this microchannel, that looks like the U letter. You have an inlet, an outlet. This is basically, this takes around picoliters volume, so it's very small. You can take picoliter of blood and inject it inside this tube, and you can detect if there is any clots, coagulation. You can detect the viscosity of the blood as well. In this case, we have injected bacteria into this microchannel, and we have investigated the activity of the bacteria, okay? For example, if we introduce nutrients to the bacteria, what will happen? And then we get such signals. So this system allows to investigate the activity of biomolecules at very small volume. Also, we use the same technology for the detection of vitamin D, okay? Basically, when you have aptamer on the surface, or this bioreceptor, when it attaches to the vitamin D, you have deflection. And by the way, this sensor size is around 2 micrometers by 1 micrometer, so it's very small. You can have multi-cantilevers, and each cantilever is functionalized with a different bioreceptor. Finally, we have this technology based on quartz tuning fork, الشوكة الرنانة اللي أخذناها الفيزياء. Okay, this is very basic. You can use this QTF as a biosensor. Okay, it resonates at its natural frequency, and its surface is functionalized with bioreceptors. So when it binds the specific biomarker, this frequency will be shifted. I think this talk finished so early. So I have presented a lot of work here. We have published a lot of work, but what is next? Okay, currently we're trying our best to translate this research into market, okay, and make as many patients or as many people as possible benefit from such technology. I would like again to thank the College of Applied Medical Science, Department of Biomedical Technology. I would like to thank King Abdullah Institute for Nanotechnology and the research team as well. Thank you very much.
شكرا دكتور. Our next and final speaker is Dr. Arij Al-Awfi. Dr. Al-Awfi is currently serving as an assistant professor in the Radiological Sciences Department at the College of Applied Medical Sciences, King Saud University.
She obtained her PhD degree in biomedical imaging from the University of Manchester and master's degree in the diagnostic imaging with distinction from Glasgow Caledonian University. Dr. Al-Auf's primary research interests revolve around breast cancer screening, breast density assessment, and breast cancer risk within the Saudi population. Dr. Al-Aufi, welcome, and the floor is yours.
Thank you, Doctor. Thank you, everyone. I know it has been a long 2 days with a lot of information to grasp, but I'll make my presentation as light and sweet and understandable as possible, and I hope you enjoy it. So as you can see here, I'm going to talk about personalized breast cancer screening and women longevity and the effect of not the traditional screening per se, but the personalized, or as Dr. Ahmed Hersi in the first day told us that he preferred the term precision medicine or precision diagnostic for patients. So first of all, as you all know and aware that breast cancer is the most significant female issue that affects women worldwide with far-reaching implications for individuals, families, and healthcare systems. So the incidence and mortalities are the most measurable outcomes of any breast cancer screening program and the disease itself. So it remains, while there are incidence remains increased, it is the breast cancer breast to be the most prevalent cancer type with higher incidence and mortality rate globally. Survival rates, however, has been improved since the introduction of screening programs and the treatment technologies. However, still, it is a burden to the healthcare system, as I said before, and also affects every woman who got the disease. And also, we have to consider regional disparities between countries and regions inside the countries itself. So breast cancer, the effect of the disease is different between regions and between countries worldwide. So that's why the mammography screening has been introduced, aiming to reduce those incidence and mortality rates. And it succeeded noticeably from the introduction of the screening programs worldwide in the 80s. And this, as you can see here in the chart, the mortality dropped instantly after the introduction of the screening mammography. So regardless of what I will say about the standardized screening approach, breast cancer mammography screening is an effective method that has been demonstrated to reduce mortality and increase survival rates among women. Also, it reduced the introduction of screening by mammography, reduced also treatment costs and to the country and to the patient as well. Also, early detection through mammography increased the quality of life for every woman who had or received early detection and discovered her disease earlier in her life. So let's take a look at the disparities between Saudi Arabia and other developed countries such as the UK and the United States of America. As you can see, the incidence rate in the first world countries, those are two examples, but it is the same among all first world countries, that the incidence is highly very much higher than Saudi Arabia. Although the mortality rate in red here is lower in Saudi Arabia, the percentage of mortalities in Saudi Arabia compared to the incidence is higher. And this is due to many reasons, but the most important reason is that Saudi Arabia has an opportunistic or self-referred screening program, which mainly affect the stage of diagnosis where women got discovered the disease. So irregular screening in Saudi Arabia, where women are usually encouraged through campaigns by the Ministry of Health or by charity societies such as Zahra Society. They are encouraged and will be educated to go and take the mammogram, but no further step will be taken by the healthcare provider. So this will leave it to the women choice and the women level of understanding for the importance of this step. Also, the healthcare access is varies widely between the regions of Saudi Arabia. Rural areas have less opportunities to be reached by women as easily as cities such as Riyadh or Jeddah or the main cities in Saudi Arabia. The other factor is the challenges in awareness. While in October, as you all noticed, that women all usually see awareness campaigns in malls and everywhere. They can see the pink ribbon everywhere, but the awareness is still low, and the level of education is still low because of the method of application of this awareness campaigns is not that effective. So the main limitations of the standardized screening that is taken in Saudi Arabia and in the first world countries such as the USA and UK is that there are many false positives of these traditional methods, leading to additional, often unnecessary testing and anxiety for patients. The second limitation is it is unreliable for women with dense breast, which is a group of women who have a higher glandular tissue in the breast compared to fat tissue. Also, the frequency of screening is different from each country based on the regulations and the government suggestions. So if the government have a lot of fund, they will recommend annual screening, while if the government have less fund, they will recommend biannually or every 3 years. So other challenges of the standardized or the current method of breast cancer screening is that it assumes that women have unified risk and benefit from the mammography screening. Regarding of the individual variation between women. So some women may be underestimated for their risk of breast cancer under this approach, leading to inadequate screening methods. However, others are overestimated for the benefit of mammography screening, leading to the unnecessary procedure further on. So this is why we are globally, since 2018, there is an encouraged idea that women should be reached individually and based on their risk. So risk-based breast cancer screening assumes that there are women who will benefit highly from the mammography screening due to its sensitivity for them, while others will have lower benefits. So other option could be delivered to that group. So the idea is that one size doesn't fit all in mammography screening. So the tailored screening strategies will have targeted approach that to identify women at risk, and those women will be offered screening based on their needs. So individual risk assessment tools could be used here to assist those women at high risk and offer them the options, and then the women at lower risk could be offered another option based on the country's regulations. So the risk factors that are considered in breast cancer screening, first of all, there are multiple risk factors associated with the disease. However, few of them are considered in the breast cancer screening program. First and foremost is the gender and age. Women above 40 have higher risk of breast cancer compared to younger women at their 20s or 30s. Although we can see a lot of incidence in those in the 30 years groups. Also, family history, genetic factors, and genetic mutations, carrier of BRCA1 and BRCA2 breast cancer mutations are at higher risk. This is based on different multiple trials and studies that are published and recognized. Lifestyle factors could also influence the risk of breast cancer for every woman. However, I'm going to talk for the one breast cancer risk factor that is directly affects the mammography screening, which is the centralized approach for breast cancer. The breast density, as I said before, it is the amount of breast glandular tissue inside the breast compared to the fatty tissue. As you can see here in the image, these breasts are within the same size. However, this image on the right, on the left, your left, is a fatty breast where the tissue inside the breast are mostly adipose or fat tissue. And you can clearly see the the lump or the mass here, which is a malignant speculated mass. In the other breast, you can see that there is radio-opaque fibroglandular tissue that is hiding the breast cancer, which make it very, which affects the mammography screening and make it with lower sensitivity. So recent study has been investigating this phenomena with the breast cancer mammography screening, and they found that among the risk factors or the considerable risk factors, that extremely dense breast women have higher risk of developing breast cancer, 4 to 6 times more than women with family history of breast cancer. Therefore, in the assessment method, one of the main assessment method, which is the thyrochoric method, they incorporated breast density in addition to genetic factors to their risk assessment tools. So women, when they are assessed for their 5-year or lifetime or 10 years risk of developing the disease, they included the breast density category. So, for example, the Manchester broadcast the breast prediction of breast cancer study enhanced the thyrochoric model by including the SNPs, which is the saliva, and then they assess the genetic of breast cancer prevalence, and then providing the assessment for every woman included in their trial. Then they combined the breast density with their thyrochoric model to improve the discrimination. And this model was found to be more effective than traditional methods such as the Gale model, who has been validated many years. In Saudi Arabia, we conducted the study just to explore how prevalence is dense breast among the population. And we found that around 30% of the screening population are with dense breast, or the category C and D. And those dense breast tissue women, while they are not as, the prevalence is not as high as other populations, such as in the UK and USA, where dense breast prevalence is 40 to 50%. Women in Saudi Arabia with higher breast densities are at higher risk of breast cancer, reaching to 8 times higher than women with the fatty breast or at the lower quartile of breast density. So it is a very important risk factor in our population that should be considered in breast cancer screening. In Europe, in the European Society of Breast Imaging, they acknowledged after many trials that breast density should be included in breast cancer regulations, and they recommended that women with increased breast density could benefit more from a supplemental MRI every 3 years, in addition to the annual mammography screening. So I'm proposing here an approach in Saudi Arabia for breast cancer screening or personalized breast cancer screening, that women, that first and foremost, the most important thing is to be more structured in reaching every woman in Saudi Arabia. This could be done by the advancement in technology provided by the Ministry of Health. As you all know, the Ministry of Health has very effective application for every Saudi citizen, where they can see their profile and they can interact with the health provider directly. So if we utilize this tool to personally invite every woman when the woman reaches the age of 40 to book her appointment at the nearest mammographic screening clinic, this will encourage women to attend the screening more, and then we could increase the rates of survival for women rather than waiting for them to see the signs and symptoms, then going to the screening clinic. Also, in this proposal, we're suggesting that to use the Saudi Genome Project that is currently many professionals are working on it, to identify women with high risk genetically for breast cancer, and then use the first screening round to assess women with higher breast density and then offer them supplemental screening. So therefore, this personalized breast cancer screening approach will be targeting those women who will benefit most from breast cancer screening and additional screening, and then reduces the overdiagnosis for women with lower risks, then improving the outcomes for the survival of women, in addition to the quality of life for every woman in Saudi Arabia. Thank you very much.
شكرا دكتورة أريج. Now I'd like to ask our speakers to kindly join me on the stage. تفضلي دكتورة. دكتورة هنا، دكتورة أريج، دكتور عبد العزيز ومهندس معاذ. أي أسئلة المتحدثين؟ لعلي أبدأ بأخذ أسئلة المستمعين. Any questions so far? تفضل دكتور.
Okay, thank you so much, all of you, for this nice presentations. My question is for Dr. Abdelaziz regarding the deflection of the biosensor due to the vitamin D interaction. Why this deflection can occur after vitamin D interaction?
Okay, so this sensor, this mechanical sensor, can you hear me well? تسمعوني زين? Okay, so this sensor basically measures the mass change. Okay, so before vitamin D detection, you have an aptamer at the surface. This aptamer, think about it as a synthetic DNA on the surface. Okay, so once you have added the aptamer onto the surface, you have a slight deflection, and then this aptamer is very selective towards the vitamin D. When the vitamin D binds the aptamer, you have more deflection. With this system, you have a PSPD and you have a laser deflection. So with this deflection, this laser will be deflected as well, and this diode will screen this deflection, and you will see it as a frequency change, which is changed due to the mass change. Okay.
Any other questions? أسئلة؟
My question is for Engineer Muad. You said, you mentioned that there was a method where the 3D printing, bioprinting, in space, and you had magnets. So with the printed thyroid would have magnetic properties, right? So would it show, like in MRI machine, would it show the same magnetic properties as the thyroid gland, the normal thyroid gland?
Very interesting question. It wouldn't, to be honest. So the magnetization is just to move the drops in certain positions. After that, we'll get normalized, we'll get grounded, all the charges will go outside. So the idea just to keep them on place floating, that's what we use the magnet for.
Yes, but wouldn't the particles have magnetic properties?
Yeah, but it will be grounded. So we're talking, the idea is just to control the drops positioning and to keep them on space for a long period of time, been held by the magnetic charges. After they finish, they just let it be, and then it will be grounded. So all the charges will leave actually the little specimen that we do have, and it will be just a normal specimen without any extra charge from the magnetization.
Okay, thank you.
No problem.
أسئلة؟
أنا عندي سؤال.
تفضلي دكتورة.
يعطيك العافية انجينير معاذ. You mentioned إنه تستخدمون ال MRI علشان to help you for for the implants. is there other ways that you can use other than MRI because لأنه مو كل الأماكن فيها MRI والMRI مكلفة في طريقة إنه تقدر تعمل scanning body scanning بحيث وتحدد فيها for 3D printing other than MRI.
Yeah, absolutely. This is very important, to be honest. لأنه so MRI is for certain things, correct? And we know we use CT scan for something, we use MRI for something. But a question about what if we have in areas that doesn't have MRIs أصلاً. So we have كانت عندي حالة في الهند, and then the area that I was in, they don't have MRI, but we use ultrasound. And then we use ultrasound different angulation. We use calculated the software that we use, ProPlan, it's a software for surgical planning, stitch the image together to create, it's not going to be that accurate, but sometimes some areas we need to do to utilize I would say less expensive methodology. Some cases we use multiple methodology together حتى some cases we use CT and MRI at the same time, we merge them together just to get, especially if we're going, for example, in an implantable device, for example, inside. At the same time, we need to locate the ligaments and the blood vessels. So we do a lot of kind of majorities. Thank you.
أنا عندي سؤال مهندس أيضا فيما يتعلق بعد البرزنتيشن. احنا نشوف ما شاء الله الادفانسز في 3 دي برينتنج انه كل شوي جالس يطلع تكنولوجيا افضل. الان عرفنا انه في شيء بالسبيس في شيء بالارض، فبالتالي السؤال هو هل في حالات انه قلت لا احنا ما وصلنا للدرجه هذه من التقدم في 3 دي برينتنج to take care of اما complicated cases او انه كل شيء ال 3 دي is solution for everything؟
لا طبعا still 3 D printing I would say as of now it's المشكلة I cannot rate it because I don't know. I cannot rate it where is the level of maturity, but definitely from my short knowledge, no, we're in the beginnings. We are in the beginnings because we're talking about بعدين multi-printing with multiple material, multiple stem cells the same together in one organ. We're talking about intraoperative printing to print the skin, to print, for example, membrane. تخيل واحد سوى عملية بعدين while they're removing, for example, the skull. We have printers that scan the area and print on top of it. We have research in Toronto University where they do have a skin printer that you have where the burn is, they take it off. وبعدين تخيل زي so it's just you take a device and then you slide it on top and then you print. We have as of now we have a lot of limitation in printing in terms of speed. It's very, very slow, very slow. We have a limitation in terms of material, and by printing, there's a few material can be printed. We have a lot of issues with scale as well. We go down to nano, but with different materials. We cannot go to nano level with all materials to be printed. And this is an open area that we can actually make other materials to be printed. We have also structural engineering issues, which is when you print, there is an overhang usually, even if it's organ. البرنت لما يطبع cannot print on air, so you have an area of overhanging that needs a lot of support, which is a big issue with 3D printing. But there's a lot of challenges, which is cool, so we can actually solve these challenges. But what I would say, where is the end goal with the 3D printing? What is going to be? 3D printing is supposed to be a friend in each person's home. You're going to order something, مثلا online on Amazon, they will sell you the digital file. You buy the digital file and then you print. خلاص, you print علبة العطر فجأة, then you print the material. So you have a printer for example, food, you have a printer for t-shirts, you have a printer for chair, جاتك أفكار كثيرة صح? So you have a printer for everything. And there is two research in MIT. So in MIT lab, they do have two research of manufacturing. So you have a 3D printer, and then you have the, what we call it, assembly robots. And I suggest highly for you to go to assembly robots. في المستقبل, you will buy a box that has many robots that programs to shape each other. يعني البوكس هذا تفتحه to be a table. So all the robots will come and assemble themselves at a table. You finish from the table, you're going, for example, to washroom, will assemble itself to be a chair or something else. So the link with the 3D printing, that there is a 3D printing of these micro robots to create things as well. In space, we have continuous printing. فتخيل أنت when you print in space, leave the medical printing, but pipe. تخيل إن في طابعة تطبع pipe, and then the pipe will go, will extend. So now there is a big project for NASA because they wanted to print the biggest satellite, and the satellite they wanted to be 25% of Earth, and they cannot ship it on ground, so they print on space long poles بعدين عليها بيغطون اللي هو الساتلايت shield بحيث to get the يعني much proper images. So what I'm trying to say here, the printing is still in the beginning. There's a lot of things to do with. Sorry for the long answer.
في سؤال؟ تفضل.
I do have a question for Dr. Arij here. It was a very great presentation, but I would love to ask about the limitation for the scanning. You said that dense tissue would considered as a limitation. Could you please explain that point more?
Thank you for your question. Yeah, it is now established that breast density is an independent risk factor in addition to be affecting the mammography screening, where the dense tissue mask the small cancer, making it very hard for radiologists to detect breast cancer at early stages. So that is why we're looking for other options for this category of women. So they are not benefiting from the traditional mammography screening. They could be referred to MRI as suggested by the European Society, or to ultrasound if MRI is not available. Or recently the contrast enhanced mammography, which is not yet established, but it is an option for this group of women. Thank you.
I have a question to Engineer Muad. How do you think 3D printing and bioprinting will contribute in increasing the lifespan of patients?
Very good question. If somebody has a kidney failure and he got on a list for transplants, and we assume in the future that you could print kidneys, so now you're increasing the lifespan of a patient, that instead of him or her waiting all this time, you don't know whether they're actually going to pass away before that or after, they could actually have the kidney, and this will increase the lifespan. But to give you a little bit hint as well more, now we're normal people, we have our normal organs and bodies. You never know, after a while you would say, oh, my knee is just broken, I need to change my knee, I need to get longer, I need to have a stronger cage of astaghfirullah, and there's a lot of things you can go over. But there's a lot of current research for people who actually replace their healthy tissues, healthy bones, with the 3D printed bones just to accomplish some strength. And hopefully we don't reach that area, but this is where they see 3D printing can elongate a person's life. I don't believe in that. There's nothing better than the actual creation. It's very crazy to see the complexity of the bone, how strong, how is it articulated حتى من inside the lattices, التجويفات حقته وكل التفاصيل. So it's there's a lot of things there's a lot of research internationally to contribute on how can we be a superhuman or just a human 0.0, like 0.20. Don't search in this area, but you're going to see a lot of research. They're trying seriously to replace some of the current people organs and hands, and just to boost it, to have a better function with it.
سؤالي موجه للأستاذ معاذ. ليش لا زال مجال الطباعة الأنسجة لا زال ضعيف عندنا في المملكة، أو الطباعة بشكل عام ما وصلت للمستوى اللي نشوفه في خارج في البلدان مثل أمريكا وأوروبا؟ نشوف عندهم تطور كبير مثل زراعة الأنسجة، حتى وصلوا لزراعة اللي هو مثل ما تفضلت حقة العظام، المش اللي تزرع. ليش لا زال عندنا التطور بطيء إلى حد ما؟
في المايك اللي جنبك مهندس.
تمام. خلاص كلمة أخذ فينا يعني عشان توصل معلومة أسرع. سؤالك مهم. لكل شيء بداية صراحة. يعني احنا نقدر نو انسر ذس كويشن على ليش ما عندنا سيارات في السعودية، ليش ما عندنا جوال سعودي، ليش ما عندنا certain things سعودية. So دائما الأسئلة يعني كل دولة لها سترينث معين ترى، ولها مجال معين راح تتطور فيه بشكل أكبر. يمكن برا في الدول اللي ممكن اللي ذكرتها الريسيرش هذا من زمان عندهم شغال. الانفنترز من زمان موجودين في تلك الدول. يعني مثلا تشارلز هول الانفنتر حق 3 دي برينتنج هو امريكي. سكوت كرامب الانفنتر حق الاذر تكنولوجي از اولسو هيز ان امريكان. هيز ان امريكان. وغالب الريسيرش حتى يعني حتى لو تشوف في الميديكال ترى 3 دي برينتنج في الميديكال بدا في الميليتري، بدا في عام 1999. حتى اول يعني برنت حق الكرينيال يعني كانت ريبليسمنت حق بروكن بارت في السكال. فالفكره انه في كثير من العوامل تكونتريبيوت ان ذس، ولكن هو يعتمد ترى على البيرسونال افورت. انا من جيت في السعوديه كانت يعني فكرتي اني ارجع واروح ما يبقى مؤتمر لا علاقه ب 3 دي برينتنج في السعوديه. ابشرك يعني كل الكليات الطب في السعوديه الحمد لله ربي ييسر لي وجيت وتكلمت على طبيعه الابعاد just to ignite this. It's all about يعني multiple things. واحده منها اللي هو curriculum. Do we have a curriculum now to be taught 3D printing in medical field? We don't. صح؟ عندكم؟ يا سلام.
نعم عندنا معمل 3D printing.
لا لا اسف عاد صديقي هو جايبني وهذا. لا لو سمحت لا تغلط عصب. كم جامعه في السعوديه عندنا دكتور عبد العزيز عندهم؟ ممتاز جدا. متى بدا دكتور عبد العزيز؟ اول سمستر. يا سلام. هذه نقطه البدايه. ممتاز ممتاز جدا. فتوقع جوابا على سؤالك اللي هي الانفراستراكشر كل شيء لازم يكون شغال. لازم يكون فيه اهتمام من الدوله للفند، لازم يكون اهتمام حتى من المستثمرين اللي موجودين بيدفعون، لازم يكون اهتمام ايضا من المستفيدين ثانيين يعني المرضى ان يتعرفوا على التقنيه وش تاثيرها عليهم عشان ذي بوش. لازم يكون اهتمام من المعاهد الاكاديميه وناس زي دكتور عبد العزيز دكتور فيصل يعني تبوش 3 دي برينتنج يعني والله يعطيك العافيه.
سؤال الدكتورة هنا، إذا بنختار الموست cause or barrier للadoption of digital health intervention, what would it be? إذا في barriers to the adoption of digital health interventions in clinical practice.
You mean the digital innovations? What are the barriers?
إذا بنختار الأهم.
لو نختار الأهم يمكن وعي allied health professionals and how to select the best for the patients and to evaluate which one is reliable, valid. يمكن هذا وإحنا عندنا في السعودية يمكن عدم توفر الأشياء اللي يعني culturally applicable أو culturally relevant. هذه من الأشياء اللي يمكن barriers قوية. لكن I think it's from the clinicians perspective هو اللي مشكلة. لذلك في resources اللي احنا عملناها. اوكي.
تقدم الشكر جزيلا لضيوفنا ومتحدثينا. شكرا لكم جزيلا. لعلنا في النهاية نشكرهم مع بعض.
هذا البروبوزل اللي هو بروبوزنج انه يكون جزء من الابلكيشن
احنا قاعدين شغالين عليه عرفتي بس الى الان في اشياء في ستراجل بس يعني ان شاء الله نبدا شوي شوي.
فرصه سعيده.
فهم مرة رئيس الجمعية اسمها ندى الوالد.
بهذا نختتم المؤتمر الدولي الثالث لكلية العلوم الطبية ومركز التمييز البحثي بالتقنية الحيوية، وإن شاء الله نلتقيكم في السنة القادمة بإذن الله بصحة وسلامة. شاكرين ومقدرين الجميع.
It's with great pleasure and enthusiasm that we welcome you to the third International Conference of College of Applied Medical Sciences, Future of Healthcare and Longevity. حياكم الله في مؤتمر كلية العلوم الطبية التطبيقية الدولي الثالث، مستقبل الرعاية الصحية وتحسين العمر الصحي.
بنات الأشعة تطلعون؟ بنات الأشعة لين نبغى نصور صورة مع بعض. دكتوراتنا
سوري بيصير انه واقفه هنا. كيف بسرعه قاعده صورت بسرعه عشان تشوفنا. يلا بصوركم كلكم جواري. اصور صفحه؟
لا اصور الكاميرا احسن. اول واحده. تحدث. يلا صورت خلاص. يلا لا انا دور. يا بنات ها يلا يلا مع السلامة. صور شوي. يلا انا عايزه اتاكد بس ان هم 10. هنا حلو صح؟ ايه لولو بليز انت ما صورتينا والله ايش فيه؟ هذاك جوالك تحبي صوري. يلا واحد ايوه زين لا يلا خلينا كلية. مرة شكرا يوليو.
It's with great pleasure and enthusiasm that we welcome you to the 3rd International Conference of College of Applied Medical Sciences, Future of Healthcare and Longevity. حياكم الله في مؤتمر كلية العلوم الطبية التطبيقية الدولي الثالث، مستقبل الرعاية الصحية وتحسين العمر الصحي.
كلية العلوم الطبية اليوم بالماراثون تدشين مؤتمر كلية الثالث عن مستقبل الرعاية الصحية وتحسين العمر الصحي ونمط الحياة أنه يحسن الصحة ويحسن مستواها.
السلام عليكم ورحمة الله. نوح أكتب. الحمد لله توفقت إني أفوز في الماراثون، وماراثون كان صعب والحمد لله توفقت وما قصروا والله كلهم. يعطيكم العافية على التنظيم الحلو وما قصرتوا، وشكرا. وإن شاء الله نشارككم ماراثونات كثيرة بعد قدام إن شاء الله، ما حد قصر معنا أكيد، ويعطيكم العافية.
عايزين بس نكرر الشكر لكم، جزاكم الله خير، شاكرين ومقدرين، الله يعطيكم العافيه. يومين جميله وخليتوا عملنا اسهل ومرتاحين، انه في ناس ما شاء الله خبرات، الناس تتعلم منها. الله يعطيكم العافيه، شاكر ومقدر، ووصلوا شكري وشكر الدكتوره للجميع بالله. شكرا لكم، الله يحفظكم.
سلامة الله. شكرا يا قمر، شكرا على الفيديو. ربنا يكرمك يا رب. هلا ازيك؟ الحمد لله. بس الكمبيوتر مشيت. لا هذا الكمبيوتر بتاعه حطوا عليه. ايه طيب حط لنا
عرضه نحمد الله جت على ما
لا معنى الصوت هذا الصوت بس خد ال HDMI وانا على الشاشة يا دكتورة ولا المهم الصوت؟ ولا هياخد وقت؟ هو لو ما شغلناش الشاشة وشغلنا هنطلع اللي تشوفه تعالي أماني